Good afternoon, good evening. Welcome to episode 10, Spine Injuries in Sports. Right now, Nancy Flynn is putting on a poll regarding your preferences as we move forward in future episodes. Please fill it out right now if you can. It really will help us decide how we're going to schedule these and how we're going to do them in the future based on what you guys like and want, and see if we can come together with that. Again, we want to thank our speakers, Robert Watkins, Chris Yeung, and Sue Falsone, for taking their time and volunteering their time to do this. It really helps us be able to give out the free CEUs and decrease our costs. Since we're talking about CEUs, you must fill out the survey. We say this every time, but still some people have some problems with it. At the completion of the presentation, it is required by the BOC and the NSCA for the CEU certificates. If you're unable to do the survey at the end, in 24 hours, you'll get an email sent to you with the link and be able to do that. If you have any problems or issues, Nancy Flynn's email is at the bottom here. You can contact her and she'll work out what's going on. I do want to let you guys know we were doing some statistics, and since we've started this in April and done 9 previous episodes, we have given out over 10,000 CEUs. So that's been really satisfying from our standpoint to really be able to provide that to you guys. That was our intention from the beginning. So I want to acknowledge some people that are off the screen and don't come on very often. Nancy Patterson Flynn, you know from previous episodes, she's a former MLB Dodger athletic trainer. Carolyn May, who works at ASMI, has really been great in helping us with the CEUs through the BOC, and especially the evidence-based practice CEUs, which are difficult to get, and she's really an expert in doing those. I really appreciate her work. And then Nick Conte, who I don't talk about very often other than to his mother. You know, he is the owner of Conte Sports Performance Therapy in Scottsdale, and we're supported really by that clinic and being able to provide this, and he really helps a lot in the background to get these things going. We've got our speakers today. We'll give detailed introductions here in a second. Robert Watkins from Marina Del Rey in Los Angeles, Chris Yeung at Desert Institute for Spine Care in Phoenix, Arizona, and really the rock star of physical therapists, Sue Falsone, who I think everybody knows. I want to give a little preview on the next episode that we're having on November 11th. It's kind of an interesting one in regards to the use of preventing baseball injuries utilizing workload and performance metrics. People are involved in baseball at the college level and at the professional level. Really, we talk a lot about workload. These two young orthopedists have Major League Baseball experience with the Philadelphia Phillies and the Chicago White Sox, but these two guys have published, this is pretty amazing, 30 studies in the last 4 years, basically most of them on workload and the use of performance metrics to look at return to play. So we're going to have both those on. There will be only 2 speakers, but I think it's going to be pretty interesting as they present a wide variety of studies that they've done over the last 4 years. Please notice that on the Q&A button on the bottom of the Zoom screen, all the questions that we need you to ask are you should type in on that Q&A, not the chat, but the Q&A. We will take those questions and use them during the Q&A. The speakers won't respond to you because they're going to be doing that at the Q&A session. We've also asked the speakers to stick around a little longer past our 2-hour time limit. We got a lot of good comments that the people wanted the Q&A to continue even after the 2 hours. So they've agreed to stick around a little longer as we look at all the different questions that you guys have. Okay. So let's get started. Robert Watkins will be speaking first on lumbar disc herniations in athletes. As we said, he's a co-director at the Marine Spine Center in Marina del Rey. His medical degree is from Keck School of Medicine at USC. Did his residency at USC Medical Center in orthopedic surgery. He has an interesting fellowship history. Went to the Center of Spinal Studies and Surgery in Queen's Medical Center in Nottingham, England, and was part of a traveling fellowship in Europe and in the United States. So pretty diverse there. He is the Vice Chief of Staff and past Chairman of Surgery at Cedars-Sinai Marina del Rey Hospital, board certified orthopedic surgeon specializing in minimally invasive spine surgery, computer-assisted surgery, and artificial disc replacement. He is the spine surgeon for the Los Angeles Dodgers, Los Angeles Rams, and the Los Angeles Clippers. He is the creator of an app called Back Doctors app that talks about back pain for people, and he's the creator of Dr. Robert Watkins podcast. So he does those. When we get him on here, we'll make sure if that's a weekly or monthly podcast or whenever he gets bored. Okay, so he's authored papers, chapters on every aspect of spine and sports spine surgery. This is his family, Michelle, Bobby, and Tommy. We have a special interest group here with both surgeons that are talking. Their fathers are also spine surgeons. So most people know Dr. Watkins Sr., which is really Robert Watkins the third, and Robert Watkins the fourth, father and son. So I think that's pretty cool. All right, Rob?
Great, thanks, Stan. Appreciate the introduction. And as Stan said, I work with my dad, who was really the first spine surgeon to treat professional athletes. He started the Curl and Joe Clinic 40 years ago. And some of the relevant things I've learned from him, I mean, we've worked together for 17 years. We operated every Tuesday and Thursday together. And you can imagine how much I've learned from my dad, especially treating athletes. You know, it's a unique field, and 90% of the athletes we treat, especially for the local teams we take care of, we don't operate on, but we have to have a program and a system to get them back to their sport. And you know what the rules are. It's like, when can they throw? When can they hit? When can they run 50 feet? And when can they practice? And this graduated program to get them back is obviously the key. And that's what makes us different than most surgeons, is you got to know how to treat people non-operatively, because most people don't need surgery. And after the surgery, how are you going to safely get them back to their sport? Well, you got to have a program. And that's where my dad helped develop with some great physical therapists, this trunk stabilization program, quantitated 5-level program so that everybody's on the same page. And we developed that into an app called the Back Doctor. It's free in the App Store. You can download it. And so that's a big thing I got from my dad, was the rehab. And obviously, getting to know the athletic trainer for the team, the physical therapist, everybody involved, so we're all on the same page, is key. I appreciate how much I've learned from Stan when he was with the Dodgers, and with Sue when she was there too, and Nancy. It was great working with everybody, and I really learned a lot, and I'm forever indebted for the experience that I've gotten from you guys and that experience of being there. So I think I need to share my screen now. And then slideshow. All right. So somebody interrupt me if you can't see anything. Like I said, I currently, we take care of everybody with back and neck pain, but we obviously specialize in athletes. And I take care of the Rams and the Dodgers and the Clippers and the Lakers. And my dad mainly does the LA Kings hockey team and the whole USC athletic department. So guys and girls, every sport, and then LAFC soccer too. So we pretty much have experience in just about every sport there is. And then we also see people from all over the country, depending on, what their condition is. my disclosures. We own the Back Doctor app. Of course, we give it away for free, so I don't know that it's actually worth anything, but it's been a great experience. You know, the power of technology is really fun. I have my own podcast station. I've done like 60 podcasts and I've made the whole virtual consultation of videos where we can share information where people can really understand what's going on and what's the plan to get them better. And I can do a recording and then people can send it to each other with the click of a button. The power of the technology is amazing. Branching into these type of lectures over the internet is really great. And I can't wait to see how it continues to evolve. It really keeps things fun and exciting. And you can share information for free, which is really cool. So spine surgery in athletes, let me shrink that. So here's my summary slide. You know, after I put together the whole talk, I realized that, you know, one slide really summarizes the whole gist. And when it comes to spine surgery in athletes, especially in the lower back too, if you're going to operate on nerve pain with mechanical irritation of the nerve based on your exam and based on what they do, and there's a mass on the nerve on the MRI, well, that has a 90% chance of success. And my dad and I have probably operated on more professional athletes than anybody in the world and reported and produced the data. And that's basically what we found. If for the right indications, surgery's great because it treats nerve pain better than anything else. But those are the clean cases, which makes sense. And I'm sure you guys have had that experience. However, the other group of operating on an injured disc that's causing referred pain that may seem like nerve pain kind of into the butt area, but without mechanical nerve irritability on the exam, and because the non-operative program's not making progress, therefore you're thinking about potentially doing surgery because you've run out of the non-operative plan, the results of that are more like 50-50. It's more of a crapshoot because you're operating for disc pain, not nerve pain. And that's kind of the gist is identifying, does this person have a nerve pain with mechanical irritation? Is that really worth operating or not? Or is this really a rehab issue? And I'll tell you, one of the greatest things I've learned from my dad is my dad knows generally when it's a rehab issue. And his restraint in giving people time and getting into their rehab and making sure you know exactly what they're doing is key. And we can get a lot of people better without doing surgery. But you got to take on the whole problem. Let me see, I just lost some control. So your role as a spine surgeon, you got to be the patient's objective advocate and determine the risks of playing with and without surgery, stick to the medical facts of the case, communicate the same message to everybody. And that's, again, our rehab program is great for getting everybody on the same page. I've learned that it takes a lot of the anxiety and the stress away if everybody just knows what the plan is. And that's why having 5 levels of rehab is, okay, you get to level 2, you can do an elliptical, you start to do rotator cuff exercises. Level 3, you can start to swing, hit, shoot, and I can send you that program. If you email me, my email will be at the end. I'll give you the levels of how we get people back, and it's on our app, the Back Doctor. You can download it. Communication's key. After talking to the player, usually in the room, I try and call everybody involved, put them on speakerphone, talk to the agent, talk to the athletic trainer, anybody they want to hear, so everybody hears the same message. I dictate my note in front of the player so they hear exactly what I'm going to put in the note. Don't make any decisions without talking to the player first. We have a lot of people who fly back to wherever they're from. We may just get a call, say, hey, they're doing great. Can they practice or play? And we've learned we need to talk to the player and hear it from them because you never know. You get a lot of mixed messages. And don't try and do anybody a favor. And that's kind of a funny statement, but because we're doctors, we're here to do people favors and to help them. But at the same time, you know, you try and bend, you know, oh, maybe we don't need to get this test because we don't want to be an inconvenience for you. Oh, they're traveling. You see them in a hotel room. You know, it's hard. You got to make everybody go through the hoops, get the proper test, do the proper exam. Don't do too many favors. Make sure everybody follows the usual protocols everybody else does so you don't miss things. And that's hard to do in high-level professional people, and you know how it is. Never forget you're the patient's physician. For us as a doctor, and I know for you guys too, if you focus on the player and get them better and do what's best for them, everything else sorts itself out. The idea is to get well first. Don't play hurt. Put the rehab first. Do the rehab before you can play. That way you can play safely and you're less likely to get re-injured and you'll play better. And you got to conquer the fear through the rehab and the conditioning and sport-specific training so that the athlete proves that they can play and they know they can. So starting with the physical exam, I'll just point out some relevant things we look for. Obviously, we do tenderness, range of motion. One of the biggest tests is single leg extension, the stork test, where you lean back. Do they have pain on that ipsilateral side? And Dr. Chris Yeung will give a talk about stress fractures. That's the best test to pick up spondylolysis. As far as determining back versus hip, which we see a lot of that, we do a Faber test of the hip. And if it causes pain in the front of their hip, it's usually a hip problem. If it causes pain in the back, we don't know what it is. It can be lumbar, spine, SI joint, or the hip for that matter. But if it's in the front, it's usually a hip problem. We test the legs for all the dermatomes and myotomes and reflexes. The most relevant ones I just want to point out, L3 comes into the front of your thigh, and so does L4. L4 crosses the knee down to the medial part of your calf. So if the pain's in the front of the thigh, you don't know is it L3 or L4. If it crosses the knee, it's L4. L3 does not cross the knee. So that's how we know it goes from L3 to L4 if it crosses the knee. L5, the biggest part is the lateral part of the calf. I mean, that's 90% reliable. If somebody has pain on the lateral aspect of their lower leg, it's almost always L5, especially if it goes to the big toe. S1 nerve usually stays in the back of your calf, may go to the lateral part of your heel. We check vibratory sense for peripheral neuropathy. The motor exam, we all know L2's hip flexors, 3 and 4 the quads. If you have a foot drop, it's usually L5. The anterior tib is usually L5, but it can be L4 if you have quad weakness with it. But the biggest thing I highlighted here is for the L5 nerve is the hip abductor. A lot of people don't test that. Have them lay on their side, lift their leg up, push down. Because if they have any type of foot drop and weakness of their big toe, check their hip abductor, because if their hip abductor is weak, it's almost always the L5 nerve. And we pick that up in a lot of hockey players or pitchers where they stabilize on one leg. And if it drops because their hip abductor is weak, a lot of times it's an L5 nerve. And that's how we know it's L5 and not a perineal nerve problem or a piriformis problem or anything more distal in the leg. Is their hip abductor is weak, that's got to be coming from the spine and the L5 nerve. S1 nerve is the gastroc. Reflexes, patella's L4, maybe L3 too, and Achilles is S1. What about nerve irritation? All the straight leg maneuvers in the sitting position and in the supine position. The most sensitive test is a sitting slump test. Sit up straight, straighten the leg, sit up straight, touch your chin down to your chest, and it stretches the whole neural tension from your brain all the way down to your foot. If that brings on pain, that's the most sensitive test where you're most likely to pick up some nerve irritability. The most specific, which means it's more distinctly nerve pain, is the popliteal cram test, where you straighten supine, flex the hip 45 degrees, straighten the leg, straighten the knee, extend the knee, and you stick your thumb just next to the hamstring, just medial to the hamstring on the lateral aspect where the popliteal nerve runs. If that reproduces the person's pain, it's almost always radicular pain from the back as causing it. And then femoral nerve stretch test to check for the L3 and L4 nerves. Other things to be aware of, and my dad is a genius really at picking up things that aren't spine. He's made diagnosis of ALS and MS in professional athletes that, quite frankly, I think other people would have missed if they didn't see him, because he has so much experience and he knows when things aren't adding up. Fasciculations. You got a 25-year-old healthy person who's having fasciculations in their legs or arms. That's weird. They may have a neurologic disorder that needs to see a neurologist and have a proper workup. Obviously, atrophy and proximal weakness. If they can't get up off the ground because they have weakness of their hip flexors and thighs, that's going to be that on both sides. That's extremely rare. It may be a neurologic disorder. Other things, obviously, fever, weight loss, swelling in their legs are things to be aware of that you could save somebody's life if you pick it up. Night pain, somebody has pain that wakes them up in the middle of the night, that may be a tumor, because the tumor is kind of eating away the bone in the middle of the night and wakes them up when there's no distractions. So that's weird. If somebody wakes somebody up in the middle of the night and it doesn't hurt as much during the day, but it wakes them up at night, that may be a tumor, something else to look out for. Diagnostic studies. Everybody who comes to see me already has an MRI. So I put that first because we just skip x-rays and get MRIs. And MRI is a great test. It's no radiation, non-invasive. But sometimes we get too focused on the MRIs. X-rays with flexion extension to see if there's any instability are always important. And then also the bone scan with lumbar spec to check for stress fractures. You can't always see that on an MRI. The CT spec scan where it merged together, you see the red dot, that's osteoblast metabolic activity. I know Chris is going to talk about that. It's a great test. We order more of those than anybody in the country and pick up stress fractures that other people miss because they only get the MRI. So you always got to check for that. If something's not adding, if somebody has a disc herniation, you don't have to get the spec scan. But if something's not adding up in the MRI, it's still lingering, we get the spec scan. So treatments for lumbar disc herniations. We start with anti-inflammatories. NSAIDs, Indocin's a great anti-inflammatory for nerve pain. Medrol dose packs, steroid packs, and prednisone, a higher dose of prednisone, a 60 milligram taper from 60 to 40 to 20 over a 6 to 9 day course. It works better than anything. Spinal injections like epidurals, we are very aggressive about recommending epidurals. A lot of times if somebody gets an acute disc herniation, we may treat them with, if it's a small herniation, treat them with oral steroids for 2 days. If they're not responding quickly, we'll do an epidural. Sometimes I do an epidural the same day, especially if I already have a relationship with the player. We do epidurals for pain, but not weakness. We don't think epidurals help weakness. Papers, results have shown both. Sometimes the epidural can make the weakness worse. Sometimes it helps it. I don't think it changes the natural history because it doesn't take the mass off the nerve. It just treats pain and inflammation. And so we do them for pain, but not weakness. So somebody has no pain and they've got weakness, I'm not going to recommend an epidural. If they have both pain and weakness, then we would do an epidural. And then we start the trunk stabilization program right away. And our program basically starts in neutral. And Sue's going to give you a great talk about rehab and back stabilization. And you guys know more about back stabilization and rehab than I do. But our program is basically designed to not aggravate the pain. It's establishing isometric neutral position, locking your spine in that neutral position where you're less likely to provoke the symptoms. So you can start the rehab early because you're not going to cause more pain and delay the healing process. The prognosis and return to play with disc herniations depends on several factors. And it depends on what's the response to the steroids. If the steroids knock out the pain pretty quickly, that's usually favorable prognosis. If the steroids don't even touch the pain, it may linger longer. How long does it take to go through this process? And then how's their response to the rehab? And you know the difference. Some people have no core strength and other people have great core strength coming into a herniation. Estimating return to play with a disc herniation, the most impossible part of my job. It's between 1 week, and Stan mentioned this earlier when we were talking today about the range of 1 week to 6 months. Well, that's accurate. But, you know, for teams and general managers and players and medical staff, that's not really helpful. The reality is we don't know. Is it going to be 1 week or 6 months with a disc herniation? I've seen both. But what does that equal? It equals 6 weeks. You know, if somebody needs a number, you can say 6 weeks, and then we'll see how they respond day to day to these different factors. Here's a case. This is a major league shortstop, severe pain with radiculitis. I mean, he truncal shift, locked up, bad radicular pain. I mean, he looked bad. Positive straight leg raise on the left. And he's got this small herniation. It's about a 4 millimeter herniation at L5S1, and it's barely touching the nerve, not compressing the nerve at all, and did an epidural pretty much right away, and he played 2 weeks later. And it was an important game, so, you know, that obviously it wasn't the beginning of the season, it was at the end of the season, and it was a big game. He played 2 weeks later with an after acute herniation and did fine. Was able to play, and everything worked out. Another major league player, an outfielder, had this type of herniation where is a little more significant. There's a little part sticking out there, but as far as the nerve, there's the nerve not touching the nerve at all. This took 5 months to come back and play. And it kind of shows you the difference. These are them side by side. This one on the left took 2 weeks. This one on the right took 5 months. And so when general managers start to get into the numbers, well, how many millimeters is it? 2 millimeters, 5 millimeters? Does that determine the return to play? No. These are both about 3 to 4 millimeter herniations. One took 2 weeks, one took 5 months. And so it's not just the size of the herniation. It depends on how they respond. And we can't always predict that. So what's our guidelines to treat them? If people, you know, we start with, hey, if you have a real herniation and then they look bad, plan on 6 weeks. And just start with that. Everybody can relax, and then we see how they respond. Maybe they'll make it back in 3 weeks. Great. Maybe they'll take 3 months. Let's start with 6 weeks. It's a worse prognosis if they have a large herniation with real nerve compression. If they have a neurologic deficit, it's going to be a worse prognosis because then you need time for the nerve to recover. If they have severe pain, if they're 8 out of 10 and they're not responding, and that's the response to the steroids. If you give them 5 days of steroids and they're still in a lot of pain, it's going to probably take a while. And then do they have significant nerve tension signs on the exam? You still got to examine somebody and get a feel for how bad is this and how irritated is the nerve, because that may take longer. Non-operative outcomes, we don't have much data on professional athletes with non-operative outcomes. There was a paper 8 years ago that showed a 90 to 95% return, which is, I agree with that. But that means 5 to 10% don't make it back with a disc herniation. So we take for granted that they'll all make it back at some point, but sometimes not. Sometimes you hurt the disc and it never quite recovers. You can't get back to your sport and generate all the power you need to with an injured disc. That sometimes happens. The average return in this paper was 3 to 4 months. And so, if you want to feel better about if somebody took 3 months to make it back, well, the published data says 3 to 4 months is the average to make it back non-operatively with a disc herniation. Treatment timeline. This is the best case scenario. This would be a 6-week timeline. First week, no activity. And this is a real disc herniation. Somebody's really hot. If they've already done our core program, we could start level 1 really early. But for the first week, it's really better to not even do anything. Just let it kind of cool off, take the medication, potentially do an epidural. Week 2, start level 1 of the program, neutral only, walking. Week 3, get to level 2 of the program. You can do non-impact cardio like elliptical, stationary bike, jogging at 50% of the weight, start rotator cuff exercises. And I'd be happy to email you guys a copy of my talk if anybody wants it. Week 4, get to level 3 of the program, start running more rotations, sport-specific exercises, light throwing. Week 5, get to level 4 of the program. Then you can really hit all out, lifting all out, do the pitching progression. And week 6, be at level 5 and start to progress back to your sport. That'd be the ideal general scenario. Maybe this could be cut by 2 weeks. Maybe it would be extended depending on how the person responds. Surgery depends on how severe are the symptoms, what's the size of the fragment, how big is it, how much is it pushing on the nerve, what's the degree of underlying stenosis that leaves less room for forgiveness, what's the response to the non-operative program, and where are they in the season. We've had plenty of athletes that we get through, do epidurals, get them through the season because they're still decently functional, and then we do the surgery at the end of the season if they're still symptomatic. Types of surgeries for a posterior lateral herniation, which is 90% of herniations. We use a McCullough retractor, blade and spike. It's about a 2 centimeter incision. Pull the muscle back under the microscope, do a laminotomy, take the herniation out, and then close the fascia and everything closes down. That's the #1 surgery we've done in probably 100 professional athletes. However, if somebody has a far lateral herniation, which is about 5 to 10% of herniations, that's hitting the exiting nerve in the foramen, those hurt like hell because it's hitting the dorsal root ganglion, really bad pain when they stand up. We use a tubular retractor for that, where we come in at like a 30-degree angle. I do epidural injections where we transforaminal epidurals come in at the same angle. So we just use the x-ray, come in at the same angle, use a dilator, dilate up to a tube, but we use an 18-millimeter tube. Under the microscope, take the herniation out. It's a great surgery. So it depends on where the fragment is, depends on how we approach it. What's the least invasive, safest way to take the herniation out, protect the nerve, decompress everything, and save the underlying structures, mainly the facet joint. This facet joint right in the middle, you got to save that thing. So if you say you do a minimally invasive surgery, but you end up taking out too much joint, well, that's not good because that's a stabilizing structure. Return to play after a discectomy. MLD is a microscopic lumbar discectomy. We start the trunk stabilization program when the postoperative pain is settled down, usually at 4 weeks post-op. Return to play is generally 3 to 6 months. You got to complete the rehab program, be between a level 4 and a 5. You got to be in adequate aerobic conditioning. A fair amount of athletes we've treated, we've gotten back to play at 3 months, 50% actually have made it back and played in a game 3 months post-op if their season was in season. But some of those athletes have told me it takes another 3 months of playing to really feel like they're back. And I'm sure you've probably had that experience too. There's no way to reproduce the sport. So to get back, you got to get in aerobic conditioning. Sports-specific exercises have to be completed. You got to reach the level of skill to play your sport and for the team to depend on you. And you got to continue the program after you've returned. And that's key to not get a re-flare-up of pain. Our results, we published this 8 years ago now. It was 85 pro athletes. Return to sport was 89%. The average was 5.8 months. But sometimes we operated on like a football player and their season didn't start for 8 months. And so it can extend that number. And it depended on where their season was. But the most relevant part too I liked was what 50% played at 3 months if their sport was in season. But the average return I plan on is 4 to 5 months. 3 months is a little early. You can make it, 50% did, but that's about as soon as I'd recommend anybody go back. Which is different than most normal people. You know, and most surgeons think, oh, you do a discectomy, you can go back to your life in a week. Well, that's true if you have a desk job. You're going to be a pro athlete. You want to be 100% before you go back, or at least close to it. What about results of discectomies in the general population? We got some good, really relevant data. This is 30,000 patients who underwent a lumbar discectomy. 78% had good to excellent results at 6 years post-surgery. That's long lasting. Another relevant study was the SPORT trial, which has a lot of great data, that 500 patients, and it basically showed that surgery, a discectomy in the lumbar spine, was superior to non-operative treatment in relieving symptoms and improving function both 4 years and 8 years after the surgery. That's really great long-term outcome data. Does the surgery lead to future problems? I know athletes will ask you this, everybody asks. What's the risk of a recurrent herniation at the same level after the surgery? It's between 10 to 20%. The incidence, but check this out, this is non-operative. What's the incidence of recurrent pain in people who didn't have surgery? Between 1 and 3 years, it went from 20 to 50%. So even if you don't have surgery, what's the chance that level will still bother you? It's between 20 to 50%. Up at 3 years, it's up to 50%. So the disc has been injured. We may do the surgery and take the piece out. People may have some future issues. Well, they have future issues even if they don't have surgery because the disc has been injured. What's the best way to prevent problems from the disc? Do the rehab. Get your core strong, get your muscle strong. Do that for the rest of your life to keep the stress off the disc. What about future degeneration of the disc that leads to degenerative disc pain that requires a fusion? It's about 5% at most. And that number is the same if you have the microscopic discectomy or you don't. And so doing the discectomy does not increase the risk of needing a fusion down the road, which means the discectomy does not cause more degeneration of the disc. So that's pretty good data that we have on that. So the answer is no. Does the surgery lead to future problems? No. Are there risks of the surgery? Yes. There's a risk about 1 to 2% of having a spinal fluid leak, nerve damage, infection. You know, things can still happen with surgery, but overall, it's a safe surgery. What about laser spine? I hope we never have to talk about this again. The Laser Spine Institute went bankrupt, but their ads were all over ESPN a couple of years ago. And there was a study that showed basically people who had laser surgery had more back and leg pain at 1 year post-op and more reoperations. So the laser just never made sense. It was just a marketing gimmick. If you do surgery where you take the disc herniation out and relieve the problem, then you use a laser at the end, that may be okay. But using a laser to burn the disc herniation, you risk burning the nerve, and it never made sense. Endoscopic surgery, where we use a microscope, using an endoscope, which can have a smaller incision, the technology has really gotten better and the visualization has gotten better. And I've seen some great results, and I know some surgeons who have gotten good results, and I trust them. And it's got really promising potential. But you got to keep in mind that any minimally invasive technique, you still have to safely protect the nerve. Can you see the nerve? Can you protect it? Can you take out the pathology? And can you save the facet joint and the pars? And also decrease the chance of having recurrent symptoms. So sometimes when we do our laminotomy, we make more room for the nerve, which may help long-term because there's more room for forgiveness. If somebody gets a bulge to the disc, well, there's more room for forgiveness if you've done the laminotomy. And if you do it so minimally invasive, maybe you don't make enough room, the person can have recurrent symptoms from the disc bulging in the future. So those are all things we consider. And here's a case that I actually just saw this last week. this patient had a minimally invasive surgery by somebody who really, gives lectures and is one of the kings of minimally invasive surgery. And this, you can see this big white path right here. This is the facet joint on the right side of this, I'll just say the right for this picture, even though it's backwards on an MRI. This facet joint is intact. This facet joint looks like they took half the joint to decompress. And this is the same patient, one cut down on the MRI around the disc level. And you can see that the stenosis isn't even relieved. So it looks like they took out half the facet joint and didn't even relieve the stenosis at the disc. And this person's still having symptoms. So yeah, they've got a small scar, minimally invasive surgery, but they took too much joint and didn't relieve the problem. So anyway, there's problems with everything we do, and those are the considerations we take into account. So let me show you some cases. This is an NBA power forward, 3-day history of right S1 pain and weakness, unable to get up on his heel, could not get his heel up off the ground. And this is his job, power forward, you got to have your calf. And he's got a disc herniation. You can see down here pushing on the S1 nerve. And I told him, look, you're probably going to need to have surgery for this. He really didn't want to have surgery. And I said, well, it's only been 3 days. So we got some time. I'll usually give people a week or two. If the nerve starts to recover, you can wait, because that means it's not being traumatized that bad. But if the nerve is not recovering and the strength is not recovering, you want to do surgery sooner, because the sooner you do the surgery, the better chance of recovery. But usually you can wait. You can wait a week or two, see if it starts to bounce back. So I did an epidural on him and an S1 nerve root block. It relieved it. So his pain was gone right away, but he still got the weakness. So I examined him twice a week for the first week, and the second week started to spread it out, and his gastroc started coming back pretty quickly. And so ultimately we didn't have to operate on him, but it still took him 3 months to make it back to full strength and to be able to play. Here's another case of a non-operative NFL player. Look how big that disc herniation is at L5S1. That was probably 7 millimeters. He did not need surgery. We were able to treat that non-operatively. Another NFL defensive lineman, he had played 15 weeks with this big of a herniation pushing on the nerve. He could still play. He did not have weakness, was able to play, but then he developed weakness. And so we got a new MRI, showed the herniation had gotten bigger, had the calf weakness, so we operated on him. And he made it back to play the next season. Another NBA forward had this disc herniation down here at L5S1. Pretty bad stenosis overall and compression of the nerve. Did an epidural. A week after the epidural, he developed calf weakness, got a new MRI, extruded the fragment. Now he's got a massive herniation. And so did the micro discectomy. He returned to play 3.5 months after the surgery. 25-year-old infielder, right L5 radiculopathy, had about a 6 to 8 millimeter spondylolisthesis at L5S1. So the herniation's in the foramen at L5S1 with the pars defect and the slip, hitting the L5 nerve, causing a foot drop and weakness. We almost always do fusions on those because it corrects the slip, locks it in place, and treats everything. But we looked at his MRI, and the herniation looked like we could get it from inside the canal with the microscope. So we just did the microscopic discectomy and didn't fuse him. And he ended up returning to play 3.5 months post-op, which was pretty surprising. Usually with a big slip, you think you got to fuse it. But in his case, we're able not to. And sometimes we'll do the microscopic surgery and tell people, look, you may have to have a fusion, but it's worth the risk of doing the microscopic surgery if we think it has a good enough chance of helping you, and avoid the fusion. And we're able to in him. What about results of fusions? The only real paper in professional athletes was in hockey players. 8 out of 8, 100% actually returned to play after a fusion. And they returned for a 4-year period of time after the fusion. And there was no difference between games played before and performance before and after the fusion. So actually pretty promising results. But I got to tell you, if you want to get good results as a surgeon, operate on hockey players, because they're tough and they're going to go back and play no matter what's going on. In our experience, lumbar fusion in pro athletes, we've only done about 3 in 15 years. We almost never do fusions in pro athletes. We almost always treat them non-operatively, maybe do a microscopic surgery, but we've done 3 in 15 years. And in our experience, in other cases we've seen from across the country, is if you have a 25 or 30-year-old who's missed an entire season after the fusion and then tries to return to be a professional athlete, the prognosis is poor, because there's other people who are there to take their jobs, and the chance of them to getting back to that high level is just very difficult. It's different than if you have a 16 to 18-year-old kid with a spondylolisthesis from a mechanical problem that you correct it, and then they still have a couple years to mature and to grow into their body, their prognosis is much better. And there's been a couple athletes with spondies that have been corrected when they were 17, 18 years old who have made it back and played in the NFL even. But it's a different type of case. Here's a player we had, a 34-year-old pitcher. The had a discogenic pain, 15 months, never getting better. We did a fusion in the front, got a successful fusion, but he was still symptomatic and wasn't able to make it back. Artificial discs are another option. They preserve motion. But this CT scan shows the artificial disc coming out the front. Sometimes they can dislodge and fail and have issues. Artificial discs are really good in necks. Lower backs, it's a little more risky. We're much more conservative about them. Artificial disc in athletes, there's only been one report in Europe that reported one pro soccer player that made it back to play after a lumbar artificial disc. But he also had one pro golfer, one pro wrestler that didn't make it back for other issues, and one karate instructor that could not compete due to pain with rotation, potentially facet pain after the artificial disc. Whereas with the fusion, you don't get facet pain because it fuses the facets as well. Toughest cases are lumbar disc herniations without significant radiculopathy. The players struggle to finish the season. Next season starts in 3 to 6 months. So if they're struggling to get through, are they going to get better in the off season and with the rehab program? Or are you going to wait through the off season, and then when they start ramping back up again, they're going to flare up and have pain? Those are the toughest. I had one today. Those are the toughest cases to treat. Our general treatment plan is give them time to rest, rehab non-op, at the risk of them not being ready for the next season. Potentially do a microdiscectomy if there's any indication they have nerve pain and nerve irritability, do the microscopic discectomy. Or your last option is to jump into the fusion, the reconstructive surgery. We almost always do the first, try the non-op, then potentially the second, the discectomy. We rarely do the reconstructive fusion. Returning to sport is determined by controlling the rehab and directing it. My dad always says if you don't have a non-operative plan and program, you can't give proper advice on whether to have surgery or not because you don't have alternative treatments. Our program, I'll skip through this. Sue's going to mainly talk about the rehab. Neutral, this is my dad a long time ago. Balance and coordination, because eventually you got to get up off the ground and to get back to your sport. It's 5 different levels. That tells us how strong is the core, what can they go back and safely do. It's all 7 different exercises rated 1 to 5. Everything's on our app. It's and neck exercises too are all in there. And that's free at the App Store under the Back Doctor app. And there's my email, robertwatkinsmd@yahoo. Please reach out, email me if I can help anytime. And thank you very much. Appreciate your guys' time.
Thanks, Rob. That was great. I've got a lot of questions for you afterwards, and some of the information on that. We're going to go ahead and move on to an introduction for Chris Yeung. Thanks a lot. Okay, our next speaker is Chris Yeung, and he's going to be talking on pars fractures in athletes. This is something I'm very interested in, and he's done a lot of work on this, especially in the younger athlete. And our sports specialization last month kind of leads right into this particular problem. He's board certified, fellowship trained orthopedic surgeon with special interest in minimally invasive spine surgery techniques. He's a graduate from University of California, San Diego, and graduated medical school at University of Southern California. He attended University of California, Irvine for his orthopedic residency and completed spine surgery at USC Center of Orthopedic Spines in Los Angeles and a fellowship under Dr. Robert Watkins III. And he has told me specifically that he was I think 3 years ahead of Dr. Watkins, so he is the senior fellow on this thing. He is board certified, fellowship trained. He's been a principal investigator in many FDA studies. He's authored numerous articles and publications. He's the team spine surgeon and consultant for the Arizona Diamondbacks, the Arizona Cardinals, Chicago Cubs, Kansas City Royals, Colorado Rockies, Los Angeles Dodgers, LA Angels, and Cincinnati Reds and Arizona State University. He has a very busy spring training. He's also one of the owners of the Phoenix Rising soccer team. And I think he wanted to make a big deal that they won 20 games in a row last year, so that had to do with ownership, I'm sure. This is his family, and as I said before, there was some similarities between the Watkins and the Yeungs, and the fact that Chris Yeung learned from his father, Anthony Yeung, who is a spine surgeon, and they work together as well. Okay, Chris, it's all yours.
All right. Let me get this slideshow up. All right. Well, I hope you guys can hear me and everything. Thank you, Stan, for having me. Very honored to be here and talk to everybody, and especially to reunite with Rob Watkins and Sue Falsone. You know, as you said, I've met Rob, oh gosh, a long time ago, in about 2000, so about 20 years ago, when I did fellowship with his dad. So I owe a lot to him and his family, and his dad, you know, taught me a bunch of stuff about spine, and especially how to treat athletes. And, you know, it's funny because when I listen to Rob speaking, I just picture his dad, because he's got such the same mannerisms, the confidence, charisma. So it's good to see Rob doing so well. And, you know, I think we kind of had a little bit of a bond immediately when I was in my fellowship, and he was a fourth-year resident. You know, just having both have fathers as spine surgeons, you know, we could commiserate a little bit, and also, you know, it was way more good than difficult times. But it's kind of interesting, you know, when you're in practice with your father, and, you know, even now when I'm like 20 years into practice, you know, I'm still the son, so still gotta defer a little bit to the father, the man. So that's kind of an interesting thing with Rob and I that we share. And Sue, gosh, I met Sue when I moved here to Phoenix, when she was working at then Athletes Performance, now Exos, and then continued to work with her when she was with the Dodgers. Stan introduced us, and, you know, Stan helped get me involved with the Dodgers when they started doing spring training out here in Phoenix, just to get part of that spring training team. So it's nice to be able to be here in Phoenix and work with all the MLB teams, and helps also keep me in touch with Rob, and, you know, connect with all those LA teams. So Stan asked me to talk about pars fractures in athletes, diagnosis and treatment. So first off, let's just kind of define what the pars fractures. Rob did a great talk about all of the general conditions of the spine and operative conditions, and just a lot of how to manage it in athletes. So for the spondylolysis, which is a pars fracture, it's called a fracture of the pars, which is the pars intra-articularis. So this is the part of the bone between the two articular surfaces of the posterior elements. You have your superior articular facet right here, and the inferior articular facet right here. And so that bone in between it, that's the pars intra-articularis. And so a fracture is represented right here on the lateral view and the axial view, showing just a little fracture. So typically, when this gets injured, and you can imagine, you know, it's a posterior element of the spine, so you injure it with extension. You're putting a lot of pressure on it, a lot of extension, a lot of rotation, and it doesn't fracture right away. You know, there's what's called a stress reaction initially. So all that repetitive motion and pressure, you'll get some swelling in the bone, and this is what's called the pre-lytic stage, or there's no fracture. This can obviously progress to acute fractures, which would be termed spondylolysis. And that's when you have the little fracture line, and that can be on advanced imaging and x-rays. And eventually, with time and natural history, this may lead to instability, where you have an anterior slippage of that bone that has the fracture going forward, because it's not attached to the posterior elements anymore. So that's often when people start getting some leg pain because it pinches that nerve and it's unstable, and they might need stability and fusion later on. So some facts here about the spondylolysis. In general, it's about in 4 to 6% of the general population. So not that common, but it's there. In athletes, it's a much higher percentage. So some articles I read that said 52% of athletes who are presenting with back pain have a spondylolysis or a stress reaction. And this is in adolescent athletes. There's some estimates that about 15% of all college football players might have a spondylolysis, and 11% of female gymnasts. So it's very, very much more common in athletes. More common in adolescents. So interestingly, if an adolescent injures the spine, about 70% of those injuries are somehow in the posterior elements, the posterior part, the facets, the pars, or even the ligaments out there. And there's an article that said 47% of adolescents, not even just athletes, but adolescents complaining of back pain might have a spondylolisthesis. So when it's adolescent, you should have a high clinical suspicion of a fracture. Adults, they're more mature with their bony skeleton. They're more apt to have strains and sprains and disc injuries, because that's just kind of more wear and tear on that disc and herniations that Rob was talking about. So when people do have pars fractures, typically where its location is typically the lowest level at L5. That's by far the most common area, but it can be anywhere. It can be anywhere in the lumbar spine, can even be in the thoracic spine. I've seen a javelin thrower at ASU, and he had mid-thoracic pars fractures. So it can happen anywhere. A lot of times they're unilateral, but they can switch to be bilateral, and they don't happen often they don't have to happen at the same time. You can have one on one side, they can recover, do well for a long time, and then they get a fracture on the other side. So that's one of the reasons why this particular type of injury is pretty frustrating, not only because it takes a long time to heal and everything, but as we'll talk about later, there's no like gold standard algorithm on how to treat these. And once you heal one, you can always re-injure it. And once you heal one, even with surgery or anything, you could injure the other side. It's all part of the sport and the repetitive actions and stuff. So again, athletes doing a lot of repetitive hyperextension. Gymnasts putting a lot of strain on their spine. Football players, especially classically, offensive and defensive linemen, because they're hitting and extending. So a lot of forces on the back of the spine. Weightlifters doing the deadlift, especially the Olympic lifting, huge incidence. Wrestlers, baseball players, especially pitchers, I think we see a lot, and infielders who are twisting a lot, doing throws. They're putting a lot of stress on their back, especially the posterior elements. Volleyball players, diving. I read one article where it said diving might even have the highest percentage of pars fractures. So what do they usually present with? Typically, patients will present with progressive back pain, and worse with lumbar extension and rotation. That's because it's in that posterior aspect of the spine. Often, about 40% of the time, there's like one inciting event. They can say, hey, there was this pitch I threw and I felt immediate sharp pain. Usually they're able to kind of keep going through that inning, but then it'll tighten up. 60% of the time, it's more of a gradual onset. They can't pinpoint exactly one episode. They can just say, hey, I had a tough weekend, that's really overexerted, and then just kind of been sore ever since, and then can kind of progressively get worse, can wax and wane. But yeah, majority though are associated with some sort of athletic event, about 93% in one study. And again, it's mostly back pain, focal pain right there in the back. Rob kind of differentiated between nerve compression pain, where it's radicular and going down the legs, versus kind of localized pain, with a fracture, it's just going to hurt right there. You can certainly have some instability and associated with disc herniation, or even some chemical irritation on the nerve. So you can get some radicular pain, but it's not as common. So physical exam, it's fairly non-specific, but you'll typically have some pain with local palpation, either on one side or the other side, if it's unilateral or bilateral. You'll have pain with lumbar extension, rotation, and flexion. And as we talked about, there's the Stork test. I'll talk about the next slide, but that's where you extend while you're standing on a single leg. You can have spasms, just reactive because of inflammation and the pain. Because of all the spasms and the tightening of the posterior chain, the hamstrings can get really tight, and that can put you in a forward kind of flex tip, bent knee kind of position. You can also present with hyperlordosis or even hypolordosis, but more traditionally hyperlordosis. And even though radiculopathy is uncommon, you can have some radiculopathy, radicular pains in the buttock, sometimes down the hamstrings, and sometimes you can even see a little bit of L5 weakness. And that's usually from a disc bulge or just intense inflammation. So Stork test that we talked about, this is the kind of pathognomonic test for pars fractures. Again, standing on one leg, extending backwards, and doing it on the opposite leg. And typically you would have pain on the same side of your fracture when you're doing this. But, while this is a sort of a specific test, there's been a lot of literature saying it's low sensitivity and low specificity, but it's kind of one of the best things we have to sort of differentiate it from discogenic pain and stuff. So it's still classically talked about. Okay, so how else are we going to diagnose this? So the athlete's going to come in with back pain, and that can be a lot of things. And if it's just persistent, first thing to do is get an x-ray. So typically we would get an AP, lateral, and flexion extension x-rays. And that's it usually. Those are the best studies, initial studies to diagnose a fracture. Some studies say 84% of pars fractures are diagnosed just on the lateral x-ray. So that single lateral x-ray is the most important view to get. Classically, people talk about oblique x-rays because that can give a more profile of the pars. So that's very sensitive, but that's not necessarily required because usually, again, 84% of the time, you don't need it. You've already made that diagnosis. And in most of the patients, if you suspect it, they're an athlete, and clinically you suspect it, you're going to get ordered advanced imaging anyway. So in these adolescents, everyone's worried about radiation stuff, so you don't necessarily need to get the oblique x-rays. But it's talked about, it obviously shows the fracture the best. You heard about the collar of the Scotty dog. This is a description right here, or illustration of an oblique x-ray. Here's the pars right here. Here's the fracture. That's where the spondylolysis is. And then again, if it progresses and slips forward, then you get that spondylolisthesis. And here, it's just the x-ray of the Scotty dog. Here's the ears, here's the snout, and then, here's the collar right there. So that's classic, but we don't typically order that. Next step, advanced imaging. So if you suspect a fracture, you're going to get an MRI. And so that is the typical initial screening test. It's nice because there's no radiation, so there's no real downside to it. So it's a good screening test, and it's actually pretty sensitive. So last studies say it's about 84% or so sensitive and picking up posterior element pain and pars fracture. It's interesting though, because and Rob will probably concur, we'll see the patient, we suspect it, we order MRI, we see them back, you read the report says normal. You're like, oh, okay. But then you look at yourself and you're like, no, it's not normal. There's this high signal change right here. And, that looks like a pars fracture. I think the radiologists probably miss about 25% of these. That's why it takes a combination of clinical exam and looking at the MRI. So here in the MRI, there's different spins. The T2 spin highlights some water. which shows up as bright. And so classically, you'll have high signal or bright signal on the T2 spin. This is a sagittal view showing here at L5 a little bit of high signal here in the pars and in the associated pedicle. You compare that to other levels. There's other spins like this inversion recovery fat suppression spin, which really gets rid of the associated fat, which can also look white on a T2. And so when it gets rid of that, it's purely inflammation. So you look at both of these to be able to tell if there's acute inflammation or if there's just fatty change from like a chronic fracture. And so here's the axial view. You can see the pars fracture here and a little bit here, and there's some edema and swelling here in the pedicles indicating an acute fracture or high signal change. There's classification showing what grade these are. Normal is grade 0. If there's a stress reaction, it's a grade 1. We're showing marrow edema, but there's no fracture lines. Grade 2, incomplete fracture, there's marrow edema with a high signal change, and you see some cortical irregularity, which indicates at least a partial fracture. And you can see actually a cortical line going through the whole thing with the marrow edema, and it's a complete fracture, and then it's a grade 3. If you see there's no edema, but you definitely see anatomic fracture, then that's a grade 4, and that's a fracture non-union. So practically you treat these, 1, 2, and 3, very similar, and then 4, more like pain management. So the other tests you can do are SPECT scan and CT scan. So SPECT scan, this is the most sensitive scan, and I can attest that Bob Watkins, they probably do order the most of these in the country. As I remember in my fellowship, Dr. Watkins will say, hey, you always got to get that SPECT scan. You're going to miss things on MRI. So we ordered a lot. I think the MRIs have improved a little bit with the 3T MRIs and just, clinical acumen. I still order SPECT scans, but probably not quite as much. But they are the most sensitive test to diagnose the pars fracture. So if you have an equivocal MRI or you just can't find out what the reason of the pain is, you get the SPECT scan. It can also show fracture healing and differentiate between acute and chronic fractures. So if you look here, this is the axial view. This is the right side, because on this axial view, it's like the head's going into the screen and the feet are coming out at us. So this is the right side here, and this is the left side. You can see this is very bright. And so that's just an active, reactive area of an active fracture. Here, this is the same patient. This is 4 months later, did well, and then re-aggravation, you can actually see it's cooled down a little bit on that right side, but then the left side is a little bit more bright and active. So that's showing how, you can heal one side and then just put stress on the next level. CT scan. So this historically has been the gold standard for diagnosis, and that's because you can really see the bony anatomy here. Here on the sagittal view, you can see this complete fracture going through one cortex, the other cortex. On the axial view, you can see the fractures going across right there also. This CT is also very useful for staging. You can see early fractures or incomplete fractures, just a little line, progressive fracture, a little wider fracture line with some fragmentation there, and then terminal or end stage or non-union is where it never healed, it's gapped, and then the bone is reacted and changed and become really thick and sclerotic. And you know that these ones have an opportunity to heal, but the terminal ones don't. And there's a really nice study by, I'm going to pronounce it wrong, but Cyro brace study, and they classified these based on MRIs and CT scans. And early fractures with a high signal on the MRI on T2, they had an 86% chance of healing with non-operative care. Progressive lesions with high signal, about 60% chance of healing. But if they were progressive looking, but no high signal, meaning no acute inflammation, like almost zero, there's zero chance for that's going to heal. And same with the terminal ones. So that's a fracture non-union. At that point, this is where you change your treatment algorithm. When they're coming here, your treatment goal is just pain management only. Here, you're actually not only doing pain management, but trying to get it to heal potentially. And then just the early versus progressive stages, It just takes a lot longer, because in this study, it took 6 months of bracing for the progressive stages to heal, and there's only 3 months in the early stage. So that goes to the non-operative treatment. And, one of the frustrating things about this diagnosis is there is no gold standard. A lot of people do a lot of different things. So I train with Rob's dad, and so we have a very similar treatment plan. Initial goal, alleviation of pain. Let it cool down, right? Get some anti-inflammatories, maybe steroids, and just cool it down. Rest, avoid activities, at least 6 weeks. Possible bracing, I don't typically use a brace unless they're really hot and just, any movement hurts. That can sometimes help with pain control, but the brace doesn't actually make it heal. It really just makes the athlete more compliant in not doing activities that aggravate the pain. So if you need that, if you need to put little reins on your patient, then maybe you can use brace, but you don't want to use it too long because you can get muscle atrophy and stuff. And then, obviously starting the trunk stabilization program. You can start that at week 1, week 2, just whenever they are able to do it comfortably. And again, 7 exercises, 5 levels of difficulty. Rob went through the different levels. Adjunctive treatments. So this is a little controversial, not great studies on these, on how they help, but bone stimulators, which help bone fractures and fusions heal. These can be used. Orteo or Timlos injections for osteoporotic compression fractures. This can help metabolically stimulate the bone to heal. There's been some studies on just long bone fractures and non-unions that they help. Typically, if patients can afford a bone stimulator or something, then people do it. And kind of in our professional athletes, they got millions of dollars riding on their ability to do a job. Hey, why not just throw the kitchen sink at them and do all this stuff? It's not going to hurt. It's just going to, hurt the pocketbook of the team or the patient. And then the final endpoint is pain control. And that's either with or without healing, because if it heals, great. If it doesn't, a fibrous union can still lead to a good clinical result. So you see lots of patients out there playing. Again, here, back doctor, I'm just giving a plug to Rob because this was awesome, because when I finished the fellowship, I had like a 25-page handout that I give to people. Now I can just give them the app, and it's great. And so just want to show you, like, a little plug for Rob here and his dad. This is my iPhone. When you go on here, you just click on the Back Doctor app. You can click on the Watkins Back Program, click any of the exercises, shows you level 1, gives you position. You can look at the technique and then tell you the goal. You can easily swipe to the left, and then that'll go from level 1 to level 2, level 3, and you can just see the differences. But it's just really easy to use. You can take this wherever you go, on vacation or whatever. So it's really nice and convenient. And they got some good advice here. So one of the preventative programs, I just, was looking at it the other day, take a vacation whenever you can. Who doesn't want to do that? So I thought that was a nice little nugget. All right, so acute pars fracture, return to play guidelines. Rob kind of went over this, kind of similar to all of our rehab things. You got to do the trunk stabilization program up to level 3, 4, 5, depending on what level you are as an athlete. You want to have aerobic conditioning that's adequate, so build that up. Start going to sport-specific exercises once you can stabilize your spine and protect it. And then obviously you got to have the level of skill to perform your sport, and then typically continue the Watkins Back program for at least a year just to help prevent recurrent stuff. So typically in terms of specifics for spondylolisthesis acute thing, 3 to 6 months out of sport. Trunk stabilization for the first 6 weeks. If you're asymptomatic, then you can gradually return to the sport-specific activities over 6 weeks, continuing the back program. Earliest return to play is typically 12 weeks. There's a saying that you can't rush biology. So you want that to either fuse, give it a chance to fuse and heal, or form a nice solid fibrous union. And you can't accelerate that. A lot of patients will have high pain tolerance, and hey, I feel great, but you know what? You can't rush biology. So you just gotta let that heal. So, and this is one of the frustrating parts. If any discomfort, so you say you go 12 weeks, you're starting to ramp it up, and then start hurting again. Then you got to go back, and you kind of got to go back to activities that don't aggravate things. And so that's when this can be frustrating. So when you say, hey, pull the plug, that's not working, let's do operative treatment. Typically and classically, they say, hey, wait 6 to 12 months because there's such good results with non-operative usually. So you want to wait because people usually don't need surgery. So that's when typically you'll pull the ripcord and go to surgery. It is contraindicated to have surgery if you have a grade 2 spondylolisthesis or a slip or higher. So if you already have instability, there's just too much pressure on that, too much instability for that to get a direct repair. You have a dysplastic thin lamina, if you have a very significant amount of degenerative disc disease where back pain is going to be a problem, and put more pressure on that pars. Or if you're over 20, that's typically not a good time to heal or age to heal these type of fractures. So there's different techniques. The newest kind of technique is the Buck's direct repair through a percutaneous incision. We used to do this open, but now we can do this percutaneously, like a little stab incision. You can use navigation, and I'll kind of go over this a little bit later. You can also have some wiring, classically described, or a screw hook combo. And then, there's a question of whether you bone graft or not. Acute versus chronic. If it's acute and it's incomplete, you probably don't need a bone graft. If it's chronic, then maybe you want to put some bone graft, give it a little extra biologic to heal. And also the spec scan, if it's hot or cold, that can help determine what you need to do. So here's just an example. Through just a little needle incision, you can go and put a little wire across the pars fracture, tap it, then put this screw across and have nice control. And this is kind of cool because these screws, they didn't have these when I did my fellowship with Rob's dad. These compression screw, variable pitch angle right here, so that as it grows or as it goes across the fracture, it actually brings it together and compresses. And you can see there's good studies that show really high compression across the fracture site. And obviously you don't want to go too far because then you'll lose fixation and it won't hold it. But this is sort of like the newest technique out there. And sometimes you can do bone grafting. Typically it's through open little incision, 1 inch, but you can actually use an endoscope and just do another stab incision. And right here, get a burr, rough it up, put a little bone graft in there. This is an example of the screw hook construct. Screw in the pedicles, get a hook around the lamina and compress it. And that's another option. But as you can see, that's just a lot of hardware, a lot bigger. Post-op care, start trunk stabilization at 4 to 6 weeks post-op. CT scan typically at 6 months to assess healing. Consider return to play after 6 months if it is healed at that time. Just a couple case studies. 16-year-old, 1-year history of waxing waning pain. Original MRI showed some stress reaction here. He was seen like an outside place. He came to me like 1 year afterwards and still hurting. We got another MRI. Showed a little high signal here on T2, but on the fat suppression scan, it was quiet. So this is all fat replacement. So it's more of a chronic terminal thing and not an acute fracture. And then here you see sclerotic edges. But we did this technique. That was that patient. I didn't do that one there. And this was him at 3 months post-op. I wouldn't typically get a CT scan, but he had a fall and he was hurting. So dad wanted a extra CT just to assess it. And you can already see it's starting to have bony bridging. This is an example of a chronic fracture. This is a major league player who had a pars fracture on the left in 2012, did well with rehab. In 2013, had a stress reaction on the contralateral side, had an epidural, was great. It was great for 7 years. And then this year, prior to spring training, was deadlifting, felt some pain. It was kind of going down the legs. He flew in, we did an epidural injection. That calmed it down. He was able to train. You can see like the increased signal here, but that's fat because it's chronic. And he was able to play the whole season. So that's just showing how the progression. 7 years ago, just a little fracture and stress reaction, but now big and kind of arthritic kind of facets. If they progress and have a spondylolisthesis and radiculopathy and nerve pain, Then eventually we'll have a fusion. And, like Rob said, he's only done, him and his dad, 3 professional athletes in season. When they're playing for a fusion, it's usually reserved for after they retire or when they're an adolescent, because they can bounce back a lot faster when they're adolescent. So conclusions, arch fractures are common in athletes. You got to have a high suspicion. MRI is the best thing for initial screening after x-rays, CT spec for staging and fracture assessment. And, you look at early progressive terminal, unilateral, bilateral, acute, or chronic classifications that can help you with your prognosis and your treatment. Early acute fractures have the highest chance to achieve bony healing. And because of this, I know Stan's got a good question for me, but we'll get to that later. Non-operative treatment is long, can be frustrating, but just stay the course. There's good outcomes. And if they need surgery, percutaneous screw fixation is a good minimally invasive surgical outcome. So thank you very much. Here's just, thanks to the rest of the crew at DISC. Here's our website, sciatica.com. If you want, you can email me any questions at cayoung@sciatica.com. And thank you very much.
Great job. Thank you very much, Chris. We're going to go on to our favorite speaker. Sorry, my favorite speaker. Okay, Sue Falsone. Boy, the last time she was on, it took me 30 minutes to get through her intro, so I'm going to skip a few things in regards to all her credentials, et cetera. But she is a board-certified clinical specialist in sports physical therapy, athletic trainer, manual therapist, strength and conditioning specialist, and she can cook really well. And I forgot the yoga. So she is the owner of Structure and Function Education. Most people know her because she's the one who educates and teaches dry needling as well as other things. She went through a real difficult time with the COVID because she teaches face-to-face, so they had to shut that down. She is now back and giving courses, so go back to see her in Structure and Function and get your credentials in dry needling. She's Bachelor's of Science in PT at Damien College, Master's in Human Movement at UNC Chapel Hill. Again, her credentials are just amazing. She was a previous head trainer for the sports performance in the U.S. men's soccer national team. She somehow snuck in the Dodgers. She didn't sneak in, but she was the first female head athletic trainer in any of the 4 sports in the United States. That was in 2012, Sue, I hope I got that right. That's really disappointing that it took that long for a female trainer to be a head trainer in a sport. Previous vice president at Exos Athletes Performance. And of course, she's the owner of Structure and Function, which is a highly educational and credentialing company. She's also an author. She's wrote this book, Bridging the Gap from Rehab to Performance. And that's what she's going to be speaking on today. This is her mother, Louise, Mark, her brother, and Walter the dog, which I messed up on the last time I did this presentation. I got Walter in there, so. Okay. Well, hang on a second. Nancy, can you take me off? Okay, there we go. All right, Sue, take it away.
All right, thank you so much. You're so funny. You got all of that right except for Richard. It's Richard the wiener dog.
Oh,
I'll let you put that, right? Like I'll let you put that together with Richard the wiener dog. Anyway, thank you guys so much. Dan, that was a super, super kind introduction. I owe my career to Stan, really. He's the one that gave me that opportunity as the head athletic trainer for the Dodgers, and it was obviously life-changing in a lot of different ways. So I am extremely indebted and grateful to Stan always. And yeah, got to work with and meet Nancy, who has been a ton of help setting all of this stuff up. So thank you to Nancy for getting this all set. And, you know, I had the pleasure and opportunity to work really closely with Dr. Watkins since he was right there in LA with us. And then when we were here in spring training or in Arizona, to be able to work with Dr. Yeung as well. And you know, just a true honor to be able to work with spine surgeons who care so much about rehabilitation. You know, Dr. Watkins and his dad always really impressed me. I'll never forget the time where we had a player who was injured with a back injury, and they came down to the athletic training room and to the weight room and watched me work with them. And really because they were curious. They weren't questioning what I was doing, but they had questions and they wanted to know what we were doing and how we were doing it. And I've just never had a surgeon be that interested in the rehabilitation process before. And so I knew I was really in a special situation with those guys and just super grateful. And we've obviously stayed in touch over the years. So it's a true honor to be able to present with both of them today. I'm going to share my screen here. Hopefully I can do this correctly here. You would think after 6 months of Zoom, I would have this down pat. Are we good?
Yep, you're good.
Okay, awesome. So we are going to talk about return to high-level performance after spine surgery. And so these are my disclosures. I do have relevant financial relationships with structure and function. As Stan said, we teach dry needling and bridging the gap from rehab to performance, which I am talking about today. I am a Nike Council Performance member, so I have a requisite swoosh on somewhere, and On Target Publications, who produces my books and DVDs and audio lectures and all of those sorts of fun things. So we are going to go through part of this today. This is really my book sort of summarized in one slide. I'm not going to go through it all, but just to kind of give you an idea of where we are going to be spending time. We've heard Dr. Watkins and Dr. Yeung talk about identifying the pain generator and making sure that we understand what tissue is the issue. It's not always super nice and neat in the spine to be able to identify what tissue is the issue, but I think it's really important that we do so. And then we can wrap that into how it's working within the motion segment. We need to make sure the right muscles are firing at the right time, and that's really where the Watkins 5-level protocol comes into play. A lot of psychomotor control for me, really getting people to fire the right things at the right time. And then moving into somatosensory control, that is really where postural reflexes and balance and proprioception and visual and vestibular work all sort of come into play. And then we move down into fundamental performance, which is about strength and power, fundamental advancement, which is really about returning to foundational athletic movement. And then we have our advanced performance, which is really about sports specific type skills. So kind of keep in mind, I'm not saying that none of this down here, hopefully you guys can see my arrow. This is all highly, highly important, and we want to make sure that we're focusing on all of that. But really today and for the next 30 minutes or so, we're going to really kind of focus on this latter half of the bridging the gap continuum, for lack of a better phrase, really moving down the performance standpoint. And so to kind of get into the meat of things, when we look at that fundamental performance, for me, it's really about strength and power when we're down at this end. During some of those levels that Dr. Watkins talked about, level 3, where we kind of begin a little bit of more activity, level 4, where we can kind of start running, level 5, when we start to get more sport specific. What do those things really mean depending on what a person is doing? We need to really make sure that we are progressively loading our patients. I think as clinicians, we generally underload our rehabilitating patients. And I think that's a problem, because if we don't allow our clients and our patients to adapt to load, then they're going to get themselves into a situation when they return to sport that they're unable, their tissue is unable to handle, and they've got the potential to re-injure themselves. We heard Dr. Yeung just now, just a few slides ago, say how frustrating that can be, right? Where people are cruising through their rehab program and then they have some pain and you kind of got to go back. And that's why back rehab gets so frustrating. It's because it's often 2 steps forward, 1 step back. And if we can really prepare people for load, and we're going to define what load is and all the different things there, we really have a much better chance of progressing these people through the rehabilitation and return to play process without taking as many steps back. That's always my my desire. It's difficult to do, but you know, ideally everybody's got at least 5 out of 5 strength, right? So from a clinician standpoint, everybody can tolerate a break test on individual muscles. I think that is like the most prerequisite thing that we can do in a return to performance program. But really then it's about building strength and it's about building power. And so when we talk about strength training, that is a scary thing for a rehabilitating person to have to do, especially for a back injury. As we heard, I think it was Dr. Yeung say that a guy did great for 7 years and then he went back to deadlifting and started to have back pain again. So loading can be problematic for these patients, and we need to make sure that we progress their tissue and progress their load as specifically as possible. We have to consider time under tension principles, which I'm going to talk about next, and load intensity parameters. So we've really got to be able to understand those things. I have said it 1,000 times, and I am sure I will say it 1,000 more. I became a much better clinician the more I hung out with strength coaches. I really encourage the healthcare professionals that are on this Zoom call to hang out with strength coaches, be in the weight room, get comfortable in the weight room, understand their language. You don't have to understand fully programming, but you've got to be able to communicate, and vice versa. Strength coaches, I need you guys to befriend a clinician so that way you guys can really truly bridge that gap from rehab to performance. I think it's so important. Programming is hard. We're going to talk a little bit about some programming here. But with that caveat, I always work side by side or in conjunction with a strength coach, because that's really where they shine, is with programming and these progressions. And so we really have to tap into their expertise when it comes to a gradual progression of load. So we also want to be making sure that we're introducing power production within our rehabilitating clients as well. And that's really the ability for them to express strength over a period of time. So as we kind of look at these concepts of load, gosh, I was pulling slides for this and I was looking through some old presentations. I mean, we created the slide at Athletes Performance literally like 19 years ago. And so it holds true today though. This is athletic movement. When we start to look at kind of what different movements is, let's just start here at free movements. This is just when I've got the ability to determine how I want to move any way I want to do it. It's just a free movement. I get to pick my motor program. I get to pick my activity. I get to pick the speed at which I perform that movement in. But we know that we also have reactive movements where I don't get to pick my motor program. My motor program is dictated by the person across the line from me, or by whatever's happening at the plate, or whatever's happening on one of the bases. I have to react to somebody else's movement. We have resisted movements. Resisted movements is when I add load to myself. And I think that loading is often seen as a progression. And I want you guys to remove that from your brain. Load does not equal a progression. Oftentimes loading someone is actually a regression, because adding load to somebody's motor program can actually increase their proprioceptive awareness. It can increase centration of their joint, which is really good. And like I said, the proprioceptive awareness is really the biggest thing. So sometimes adding load to somebody's movement is actually a regression for that particular movement pattern. So definitely remove from your brain, oh, if I add 20 pounds to somebody's movement, that's a progression. It's not always the case. So keep that in mind. We've got explosive strength, so the ability to produce a lot of power. Most of the athletes and clients that I work with, they don't need to be maximally strong. Right down here, we have this max strength. You know, unless you're a true competitive Olympic lifter, you probably don't need to be maximally strong. You need to be maximally powerful, right? Baseball players, basketball, hockey, football, they need to be powerful. And that's really where explosive strength comes into play. Starting strength is about overcoming inertia. So going from not moving to moving, that takes a particular amount of strength. We've already talked about max strength. We know we can overload the eccentric component of a muscle. That's why one technique used to increase max strength. And then we have our limit strength, which is like the freakish, you know, someone's trapped underneath a car and you're going to lift the car up. And that's all hormonal and adrenaline and those sorts of things that we know come into play with competition as well. And then going back here to this type of on the continuum, we've got assisted movements. So assisted movements is when I'm running and someone is pushing me along beyond my normal limits. So we see that in football all the time, where a receiver catches a ball and one of the DBs is sort of like pushing them beyond their limits and sort of overspeed type thing. So we've got to be able to train that. And then we have altered states, which you may or may not use. I use the pool with my low back pain patients and my spine surgery recovery patients all the time, because I can utilize water to deload, but yet significantly be able to work on movement patterns and those sorts of things, and still work on resistance within the water. We also have altered gravity, lots of different fun things in this day and age. So just kind of keep in mind, when I talk about returning to strength, there's a lot of different things. It's not just about adding resistance, and it's not just about moving resistance fast. There's lots of different things along the contractile continuum that, as return to play specialists, we've got to be able to prepare our clients for. So that goes way beyond some of the stuff that we do in the earlier stages of the return to play continuum, when we're in more of that prone, supine, quadruped kind of positions. So the other thing, hopefully these all work, is to define and understand that we've got to be able to prepare for both force stabilization and for force propulsion. So force stabilization is really about anti-motion, like we're trying to stabilize against a resistive force. So whether, like, you can't really tell, but this is like a rip trainer where there's only a cord. You can maybe, oh yeah, you can see it over here from the side. You can see how there's only a bungee cord on the right side of that stick. There's nothing on the left side. So that's pulling him into a right rotation. He's really got to use all of his spinal stabilizers in order to not rotate. He's got to do that anti-motion of rotation. Same thing here, ropes. Yes, they can get very anterior shoulder dominant. You really got to make sure that you coach that and cue that correctly, so that way it's a total body movement. Same thing, lots can be happening throughout the entire kinetic chain to stabilize that movement. And then I use med ball all the time for force stabilization. You know, the arms and the hands are simply a vehicle for the ball to be moving. Everything really, from a stabilization standpoint, is kind of happening when the ball hits her hand over here. We get a lot of reactive activation of the spinal stabilizers, multifidus, rotatories, all of those things, the abdominals, as that ball comes back to her, and she has to try to prevent extension or flexion of her spine. And all of these things kind of really get to start to introduce speed of movement, which again, someone coming back from a spine injury, really difficult to introduce speed of movement because people are so nervous. I think a lot of times the words we use, the cues we use, can really create a fear avoidance behavior within our spine and back pain patients, because we're constantly telling them, I don't want you to move your shoulders from your hips. Make sure you keep everything in line. And that kind of creates a fear avoidance pattern. So we've got to be really, really careful on the words that we choose when we're coaching these back pain patients, especially as they're coming back from surgery, that we don't accidentally induce a fear avoidance behavior pattern. I think that that's something really, really important. So it's nice to start to get people moving with speed in a really, really safe way. And these are some nice, safe ways that you can do that. As we move forward into force production, this is really about kinetic linking. Kinetic linking is very spine sparing, meaning it's not that I don't want the spine to move. If the spine wasn't supposed to move, it would have been one big long bone, right? But it's 24 movable parts, and you can argue it's even more than that, because every spinal segment has a disc plus at least two facet joints, and then in thoracic spine we've got costovertebral joints and different joints is there. So right, there's actually more than 24 movable parts within the spine. So it is kind of a misnomer when we talk about spine stabilization, right? If the spine was meant to not move, it would be one big long bone. But we've got so many different connections. It is meant to move. What it's not meant to do is it's not meant to do motion that it wasn't biomechanically set up for. So like lumbar spine is a great example. The facet joints are in the sagittal plane. The lumbar spine is set up really, really well for flexion and extension. It's not set up at all for rotation. So what happens when our hips get bound down and we lose rotation in our hips, or we lose rotation in our thoracic spine, what has to make up for it? The lumbar spine. Lumbar spine was never meant to rotate. And so now all of a sudden we're trying to force rotation because we're trying to produce force. And what ends up happening is something's got to give. And what tends to give is a disc. And so if we can spare the spine by improving and getting our patients to better move through their hips and get our patients to better move through the thoracic spine and get them to move through their glenohumeral joints and their scapulothoracic joints and get their shoulders moving and doing what they're supposed to do, then the spine is simply a conduit for force transfer from the ground through the upper extremity or through the lower extremity into the upper extremity and vice versa from a force absorption standpoint. So that's really what the spine is supposed to do. You know, I don't have a picture of the abs in here, but when we look at the abdominals, just think about your rectus abdominis and how that looks compared to your bicep or your hamstring. Your rectus abdominis has a linea alba and there are fascial indentations that go horizontally across, right? That's why people have their 6-pack or their 8-pack. If the only point of the rectus abdominis was to flex the trunk because it goes from the ribs to the pubic bone, okay, great. Yes, it's a trunk flexor. If that was its job though, wouldn't it look like a bicep or wouldn't it look like the hamstrings? Yeah, it probably would. So what does the linea alba do? What do those fascial indentations do? It's all about force transfer across the front of the spine. And so really that's what the abdominals help do, is to help transfer force from the lower extremity to the upper extremity and vice versa. So we've got to be able to teach our clients that. So for me in my programming, I definitely make sure I have force production and force stabilization things within programming because I think it's important that we prepare our clients for both. As we move forward in the rehabilitation process, once we begin to move past, again, our supine prone based, quadruped based, tall kneeling, half kneeling type spine stabilization exercises, we want to make sure that we are tapping into the correct relationship and time under tension of our muscles based on the physiological effect we want to have from a musculoskeletal standpoint. So for me, yeah, I have a lot of letters after my name, as Stan alluded to. They all just simply spell nerd because I'm the biggest nerd possible. I'm taking wine classes right now, like really formal wine, because I turned drinking into school. That's how much of a nerd I am. But anyway, my first letters were PT, right? So I am a clinician at heart. I'm a physical therapist at heart. That's where I always go back to. And so 3 sets of 10, oh, that's such a lovely set rep scheme, right? Like, oh, I love 3 sets of 10. I can load it. I can watch it move. I can coach it. Oh, it feels so great. And like on a Friday, if I'm feeling crazy, it's 2 sets of 12, you know, like I'll just get crazy and kind of work within that, right? And so when we look at what that is, the typical tempo that the exercise is performed at with that set rep scheme, it's probably somewhere down here in this applied functional hypertrophy area. It really should be sort of labeled atrophy. Oops, I kind of went back. Let me go back here. It really should be labeled atrophy prevention, because that's really what I'm doing. I'm not really creating an increase in someone's lean mass. I'm not really increasing power or necessarily increasing strength, but I'm preventing atrophy. I'm getting some neuromuscular, neurological kind of connections to whatever I want to sort of wake up. And yeah, that's not a bad thing. That's where I love to live. I think it's a great place to live, but we know that's not how athletes function. So as we look, we have to understand that if I want to create strength within my client, it needs to be about a 20-second set. Oh, you guys, I knew we weren't going to make it without Richard barking. Sorry. So hopefully he stops barking soon. But anyway, relative strength, it's about 20 seconds per set at about 1 to 5 reps per set. When we start talking about power is at less than 10 seconds per set. So that is going to be really fast sets, right? Maybe 1 repetition that happens as fast as possible. That's how we work on power. And then hypertrophy, in order to stimulate a hypertrophy response in muscle, we have to have 70 seconds of tension. That is a really long set. So no wonder, you know, like ACL rehabs are really a great response or a great example of this. Like no wonder for a while back in the day, and please, hopefully I'm not the only one who's ever done this, when you're rehabilitating someone post-op ACL, right, they're doing pretty well. And, you know, the KT 85,000, whatever number we're on, is good and all their kinetic testing is good and they can hop and they can jump and they can do all their stuff, but they still kind of have the skinny little leg. Well, that's because we've never really spent as clinicians time building lean mass and in this hypertrophy phase that is like 70 seconds per set. That's a really difficult thing to do. And so, yeah, these are things that we have to think about as we're rehabilitating somebody, especially someone who's had spine surgery that had nerve root involvement that has now had atrophy and strength loss because of a neurological involvement. That's a really big deal. So we've got to be paying attention to that. So here's just an example of what I'm trying to say here basically is that from a body weight perspective, if we just did a body weight squat and we did a set of 10, if we did an eccentric phase of the exercise, so somebody's squatting down and it takes them 1 second, they don't spend any time in the isometric phase and they jump up as fast as possible, that's going to be a 1 second rep. If I had them do 10 reps, that's going to be a 10-second set. It's a relative power. That's a way for me to work on relative power. I take the same exercise, same rep and set scheme, but change the tempo of that exercise. So now they do the eccentric portion of the exercise for a second. They don't hold it. They come up for a full second. Now that's 2 seconds per rep. It's 20 seconds per set. Now I'm more in that applied functional phase. Same set rep scheme, 2 seconds on the eccentric portion of the exercise. I have them hold it for 1 second and they come up for 2 seconds. Now that's a 5 second per rep, 50 seconds per set. And now I've got the potential to stimulate a hypertrophy response. So tempo is absolutely huge. And as I'm bringing these guys back from their surgery, I absolutely am not only prescribing their exercise and their set and rep scheme, but I'm prescribing the tempo at which they are performing that exercise. Because if we're not counting this, then I have no idea what physiological response I'm really stimulating within their muscles. Guys, this is where the strength and conditioning specialists shine. This is hard, right? This is hard to do for all of the exercises that we're going to do in a given day, in a given week, in a given month. And programming is really what they do best. So make sure you have a strength coach in your pocket that you can work with because this is really where they shine. Because now, okay, so we've talked about time under tension. That's all awesome. But guess what? Load matters. So now if I'm not loading this time under tension properly, again, they're not going to get the same physiological response. So this is a lot of words. We're going to talk through it. We need enough load to stimulate the physiological response. Meaning if I want that hypertrophy response at that 50-second body weight squat, I need to have like an 80% one repetition max, right? And there's different ways that you can estimate a 1 repetition max in your client. I'm kind of getting off topic. We're not going to go down that path right now. But again, strength coaches know how to do that stuff. Make sure you work with one of them. So I really want to make sure that I am loading my clients significantly, because if I don't load them, right, and I'm just doing the body weight squat and I don't really load them, I'm going to get a cardiovascular effect, right? Like people can move fast. You're going to get an increase in your heart rate. So I'm going to stimulate a cardiovascular response, but I might not stimulate a hypertrophy response. And again, the reason why most of the time as a young clinician, I was getting relative strength responses was because I was loading people at like a 60 to 80% rep max. And again, as a younger clinician, I was significantly underloading my athletes. Athletes need load to stimulate a hypertrophy response. And so load is something that we definitely as clinicians need to get more comfortable with, because as I've already said, I feel like we significantly underload our clients. As load increases, the time is going to generally decrease. So think about how hard it is. You move really slow when you do a 1 rep maximum. And if you decrease the load, you're now doing more speed work because you can move faster. So there is this kind of time that is optimal, right? Like think about if you added 1 more ounce of weight to the bar, that you were going to start to move slower. Well, we never want to train our client to be slower. Like that's not usually a desired adaptation. So you have to find that sweet spot of the max amount of load that you can move with the maximal amount of speed. And again, that's fantastic programming and takes time to kind of understand, but it's things that we need to be able to talk about. So now as we move into kind of this fundamental advancement phase where we're really talking about foundational athletic movement, I've got to understand that athletic movement is made of all of these things. And as I'm rehabilitating the spine patient, I need to make sure that I properly load all of these type of movements. And we're not going to have time to go through all of these movements. I mean, I could talk about this stuff for 8 hours, you guys. So we're just going to kind of look at linear motion. But just to kind of understand that when we talk about return to run, what do you mean return to run? Are we talking about acceleration? Are we talking about absolute speed? We can't forget deceleration, right? You wouldn't build a car without brakes. So these are different things. And you know, I always find it funny when, you know, I think, well, is that really what it looks like? Yeah, it's really what it looks like. I love this picture. I use this picture all the time from back in 2013 of Dre. That's a beautiful expression of acceleration and a total body lean. He's got fantastic hip separation here, great arm action. He's got nice triple extension down here in his leg. That is a fantastic expression of acceleration, but he looks completely different from these 3 marathon runners, right? It's a different body position. It's a different leg action. It's pretty similar arm action, but a little bit different. So everything is totally different. So when we talk about return to run, we need to understand, what do our clients need? Offensive linemen probably don't need absolute speed. Wide receivers absolutely need absolute speed. So we've got to know, what do our clients need from that list of fundamental athletic movements. So we're just going to kind of cruise through this. I've just got a bunch of videos, and the first thing I do is what I call movement preparation, or moving mobility. And all this is really getting clients up off of the table. When we start to transition our clients, especially post-operative patients, it's scary to begin moving. So all we're doing here is different exercises for mobility, right? And I wouldn't typically have them move this slowly, although at first they might move this slowly. Tristan's doing a nice job just to make sure he's really kind of coaching the full expression of the movement. But you can have them move faster, and that's really what we're doing. We're just doing a little bit of hip rotation here, a little bit of hamstring stretching and hip flexor stretching in the last exercise, a little bit of lateral adductor stretch, hip rotation. We've already said in our spine patients, we have to restore and maintain maximal amounts of hip rotation in order to spare their spine. That is absolutely critical when it comes to power production. So we can do that in a variety of ways. And so just kind of cruising through here, you know, I typically have patients move 5 to 10 yards through this. They move back and forth. I kind of have a little routine for them. And maybe that's our entire thing. While this may end up being our warm up in another month or two, right now, workout, and that might just be their movement workout for the day, is just an active mobility. Looks very similar to yoga, where a lot of these movements are coming from, no doubt. So yeah, let's see. Let's kind of keep cruising through some of these things. Tristan, what else you got for me here, buddy? Let's look. Okay, so now this is where we're going to kind of start to get into some acceleration, because again, we've talked about load. How do we introduce load? Everybody thinks plyometric movement is box jumping, and that's not necessarily the case. We can institute low-level rapid response type movements where it's a low amplitude movement, so it's not going to be very jarring to the spine, but we can start to get people to move with a little bit of speed, which is really, really important. Here, from an acceleration progression standpoint, again, a little bit of ground reaction force, which if someone goes into back spasms or starts to have back pain with just this little bit of ground reaction force, they're not going to be able to return to running. They're not ready. And when we think about spine stabilization, what is this? This is just a pillar bridge on a wall in an acceleration position. So I've just taken that concept of a prone pillar bridge for trunk stability, put it on the wall, and now I'm having him load and lift. And you don't even have to do that second part. Just a single leg squat is all that first part of the exercise is. So a single leg squat in an acceleration position. Can they load? He's not really moving his spine there at all, right? Like everything is happening from his hip, and that's where the power production should be happening. So again, here, is he able to tolerate that little bit of ground reaction force? And can he do it without substituting at his spine? Again, not that I don't want his spine to move, but I don't want his spine to move as a compensatory movement pattern for something his hips cannot do. Hopefully that makes sense. So as we move forward, we do another acceleration progression here. So he just does a triple exchange where he pauses after 3 times. Again, if he's all over the place with trunk flexion and extension here, he's not ready to return to running. I can't have him running down the field in any way. He doesn't have enough trunk stability in order to tolerate the power production that his hips are trying to create. So again, this is just a pillar bridge in an acceleration position, introducing some ground reaction force to make sure that their spine can tolerate it. And then from an absolute speed standpoint, can they tolerate some of these more upright movements? Can they begin to move with a little bit of speed? This is a low amplitude movement, not anything that should be extremely jarring on their spine. But if it is, then okay, I know we're not ready to continue to move forward. So he's just doing single leg variations. Now he's moving on to what we call shinning, where he's going over his shin. I just use the cue. Typically think about a pole kind of being through your shin and you're stepping over that pole. Now he's doing a double leg version of shinning, and then he'll move to a single leg version of kneeing, where he is again getting more hip flexion, again, not moving at his spine. He's doing a nice job of expressing that movement through his hip. And then he will do a double leg expression of kneeing, which is good there. So then, again, I can have him working on absolute speed mechanics against the wall. So here he's just starting with singles, where he just does one claw. You can see this is a totally different leg action than absolute speed. Again, not excessive flexion and extension of his lumbar spine. He's doing a nice job of creating that power in his leg. And we're introducing a little bit of arm action, and he's moving with some speed, which builds a lot of confidence. Again, trying to avoid fear avoidance behavior patterns in our clients as they're coming back from spine surgery is really important. So these movements that create a little bit of speed give them some confidence, which is really important. And then once they're doing really well, we can express that in a triple, where he has to express that movement over and over again. And then we can do it for time. Now we can come away from the wall and we can begin doing different things on the field, whether that's sled work or different things. Again, in my brain, all progressions of my spine stabilization program, however you want to categorize it is up to you. But for me, really, these are progressions of my spine stabilization program, no doubt. We're not going to have time to go through everything, but we've got to do that same progression for linear movement in the vertical fashion. So jumping and landing, really, really important when it comes to our spine patients, because again, one jump and it sends them into back spasms is not going to be good. So making sure that we're progressive with our loading. Same thing with our multi-directional movement, making sure that they can get into an athletic base. They've got the ability to move laterally. They've got the ability to change direction. They've got the ability to cross over or to open step. And the ability to drop step, which I don't think I have a picture of, in order to go from facing one direction to 180 degrees the other. So yeah, really, and then kind of we get into this last phase here, which now we get sport specific, right? People always ask, how do I work with so many different types of athletes? And it's because none of this changes until I get to this last thing. This is where it becomes sport specific. I'm not an offensive lineman coach. I'm not a linebacker coach. I'm not a pitching coach. I'm a movement coach. And I work with and watch film and talk to and chat with and bring in the skill coaches all the time within the rehabilitation process, because really, again, this is where it becomes sport specific. And yeah, most sports are not my area of expertise, but movement definitely is. So just to kind of keep in mind, for your programming, we've got force stabilization and force production. We've got to consider time under tension and load parameters. Know the different fundamental athletic movements and the type of those movements that your clients need. Make friends with someone who has the skills that you may lack. So clinicians, find a great strength coach, find a great clinician, and make sure you guys work together in the best interest of your athletes. That is my contact information. Feel free to stay in touch. We do have I'll do a shameless plug for our new online education program. And I thought it would be fun to make the code STAN20 to get $20 off your annual membership if you guys want information on that. So anyway, lots of information on everything that we just talked about. And again, thank you for the time. Hopefully I didn't go too far over. Yeah, just appreciate everything. Thanks, guys.
Great. Sue, fantastic as always. Listen, just to the people in the room, which is like over 1,000 people still in the room and listening to this. We are going to have a Q&A as we promised. We're going to go past our time. But people who cannot stay, I sure understand that. We will have a recording of this in the next 48 hours on conteperformance.com. You'll be able to see this and go back. So if you can't stay for all the excellent questions, we've got a whole bunch of questions to do this. You'll be able to see that in a couple days to get that information as well. And you'll have the entire program that's being recorded. We'll continue recording it and give it out to you on the conteperformance.com website. One thing I just want to comment before we get into the audience questions is, I think one of the things that Sue said, that if you get, she had so much information that's pretty awesome. But the one thing I'd like to go from my perspective is, if you can just understand that the lumbar spine does not rotate, you've got this a long way. And if you're ever not quite sure about understanding this, when we talk about the pars defects, if you have a chance, go in on Saturday to a batting cage and just watch these 8-year-olds swing and throw. And they're doing nothing but rotation in their back. It all comes from the pelvis and the thoracic spine, which is a movement that they're not used to. And this is one of the reasons that we're seeing more and more pars defects in these young kids at 14, 15, and 16. And those kinds of things. We see them in our clinic all the time. And it's strictly because they swing hard, they rotate on their lumbar spine because they're so damn flexible as kids, but they're not doing it the correct way. And so just watch their rotation and their hyperextension at the end of their throwing or at the end of their swinging, and you'll understand why these injuries occur. Okay, so Nancy, let's go right after the audience questions, and then I'll throw a few of my own questions in if you guys don't mind.
All right. How does an epidural injection affect the integrity of tissue? Isn't there a limit to epidurals?
So I'll go ahead and take it. So basically, you can easily get 3 epidurals in a year with really no downside. Steroids, cortisone are synthetic. High doses in your body for long periods of time are bad. But 3 epidurals in a year has never been shown to have any negative effect, especially on somebody young.
Let me throw another question off of that to Dr. Yeung. You talked about, everyone's talked about the injections and the epidurals. What about before you get to that point, non-steroidals, dexamethasone, prednisone, and those kinds of things? How do you utilize those in the acute phase?
Yeah, so I mean, it sort of depends what you're treating. I mean, typically, if you have back pain or even some radicular pain, any of those anti-inflammatory medications like the non-steroidals, that's kind of first line of treatment. If it's not helping, then I think an oral steroid medication, kind of just shotgun approach, just kind of control the inflammation, control the pain, is definitely appropriate. And then if you're able to localize where the problem is, like one nerve, one foramen, the pain generator, then a targeted injection with steroid is appropriate. So, like an oral steroid, you're getting steroids everywhere, including the area of concern. But if you can target it, it's a little bit better. I think with the fractures, if you actually diagnose a fracture, we know that non-steroidal anti-inflammatories inhibit bony fusion. So if you actually then diagnose, okay, it's a pars fracture, then you might want to steer clear of those and maybe control the pain with the steroids, at least for 3 months.
And if I might follow up with that, Chris, I know you and I have talked about this before about injecting pars fractures. I really avoid injecting a pars fracture with a cortisone steroid shot because it may decrease some of the healing. We may do an epidural if they've got some neuritic irritability under the fracture, but we try and we've never proven that they decrease healing of pars fracture. We try and avoid that. And that may have a role for stem cell injections or some type of biologic to help heal a pars fracture, even though that's a stretch. Because the problem with the pars fractures is they need stability. They don't necessarily need more biology. They need stability. And you get stability from leaving it alone, letting it heal, and doing the core stabilization program, and then ultimately putting a screw across if it needs it. So it's not necessarily a biologic problem. It's a stability problem.
Yeah, absolutely. And I would say, you know, it also depends on the stage of the fracture. So if it's a chronic fracture that hasn't healed in years and, you know, it's just pain control, you could potentially put it in the pars fracture, but I agree, you don't want to put it right in an acute fracture.
Nancy, I'm going to jump in here on this because I wanted to ask Sue this, and people will get this on the video, but I understand people are going to be leaving, so I want to get this out. I think your analogy of a motion coach is excellent in regards to, you know, the things that we're doing now are all movements and correct movements. For the people out there, how do you become a movement coach? What courses, what kind of things, where would you go to do this?
Yeah, shameless plug for our courses, our Bridging the Gap courses. You know, so basically what we're doing is we're taking every chapter of the book and making it an online course. So actually our chapter 9, which was kind of a lot of the movement stuff, will be coming out in the next couple months. On top of that, Exos has a fantastic mentorship program. Again, I know I'm biased. I spent 13 years with that company, but that's really where we developed a lot of this curriculum back in the day. So they have an excellent, I don't know how they've manipulated it during COVID time, but an excellent 3 or 4 level mentorship program to learn more about movement. Plenty of different strength coaches, guys that come to mind, Lee Taft, Michael Boyle, are excellent people to kind of learn movement from. So I think that it's one of those things where yes, you can go to a course. Yes, you can take an online course. Yes, you can kind of do all that stuff. But at the end of the day, if you're not in the weight room and you're not with coaches who are coaching movement on a daily basis, it's really difficult. So look in your community. You know, we don't always have to take an academic course in order to gain a skill. If you look at who's in your community and who's coaching movement within your community, and I'm sure there's an easy way to do that on social media, and just ask if you can come and hang out. I mean, that's what I did for a long time, was just hang out with the strength coaches and watch them work. I think that can go a long way. You know, it's not always about a certification if you don't know how to apply those things.
Okay, so since I plugged your company, which I think is great, I need to plug CSPT, Conte Sports Performance Therapy. That's sort of what we're all into there. And I wish I would have known more about it when I was with the Dodgers and in professional baseball, as opposed to going after the movement first and really get these guys to move correctly. You know, that's important. And I say that so that Nick Conte doesn't call me tonight and yell at me. Okay, so Nancy, another question?
All right. Is hyperlordosis or hyperlordosis more likely to increase risk for a spondy? Does lack of motion cause the stress reaction with repetitive extension activity, or does greater range strain the system more?
That's a good question. I don't know. It's kind of like what comes first, the chicken or the egg? They find hyperlordosis more commonly in patients with spondies. So potentially, does that mean if they are hyperlordotic, they have a little bit more predilection to the fracture? You know, I would probably guess hyperlordotic for fracture, hypolordotic, higher chance for degenerative disc disease and disc injuries because you're kind of loading the anterior part of the spine, anterior column. Yeah, I don't know. I do think if they are stiffer, then that would probably be a higher chance for loading the actual bones versus if they have a little more flexibility, then you're using the joints and they're sliding a lot more and maybe less chance for fracture, but more chance for arthritis and degeneration of those joints. I don't know. What do you think, Rob?
Yeah, I mean, I think the first part, I think, you know, I totally agree with the hyperlordotic, more stress fractures, and hypo, more disc injuries, just, you know, as a generalization. I think the biggest thing about people building up, young kids building up strong butt and leg strength and then getting tight hips, then putting more stress on their backs, due to the inflexibility of their hips, kind of what Stan alluded to earlier, I think is definitely true. As far as the flexibility in the spine, you know, I do think that being mobile in your spine is more likely to put stress on cause stress fractures, just to the degree that we see it in those athletes who seem to be developing. And I think they lack some of that stability, and that's this repetitive action in somebody who's just too mobile. But is that really flexibility, or that they just lack strength? You know, and it's kind of like they got to, and that's what I tell kids all the time is you're 17, 18 years old and you're doing the same thing over and over again. You haven't grown into your body yet. And it may take a year to build up that kind of more man strength to take the stress off the stress fracture.
Or women's strength.
Yeah, exactly. We know women are stronger, so we say real women's strength. Men are total wimps compared to women. Anybody who does spine surgery knows that.
I want to get a little bit deeper into the pars defects in regards to diagnosis. I cannot remember a major league player or even a minor league player that had a stress fracture. So they're over 20 years old. Although there's some studies out there that are showing significant number, even in professional baseball, there's an article out that talks about them. I just never saw it. But, you know, I am seeing just tons of them in the 15 and 16-year-olds. So one of the issues I've talked with Dr. Yeung about is, how do you decide he has a stress fracture? You get a spec or you get an MRI. Probably an MRI is the easiest thing to get. Everyone's kind of into those type of thing. And they have some marrow edema. And maybe they're a grade 2 with a little bit of a fracture on the cortical fracture. How long do you keep them? You wait them until they're asymptomatic, but we know the natural course in this is that they feel really good. They start moving really pretty well. So they start going back to their stuff and they end up re-aggravating this. How do you decide that a partial fracture or a full fracture is ready to go? Because the only thing you can use is a CT scan, which you really don't want to use in a young person because of the radiation. And so how can you tell whether it's ready to go until it's too late if you send it back? I don't know if I worded that right.
Well, okay. Yeah, I mean, that's a good question. And that's one of the reasons why it's so frustrating, you know, to treat these 1 step forward, 2 steps back, as Sue was saying. You know, I can tell you it's all about the app. Once you're level 5, then you're ready to go. Right, Rob? No. So seriously though, you look at the clinical situation, what their pain relief is. And like you said, we don't get a lot of post-operative or post-treatment CT scans because, you know, that's not the goal. The goal is not to heal the fracture necessarily, it's to eliminate the symptoms. And so you kind of just got to follow them, you know, have good communication with the family and the therapists that are working with them, and to look at that. And, you know, that kind of goes into that thing. Early fractures, they're like, they have the highest potential heal. One, non-operatively, but also operatively. So Rob and I have had this discussion where it's like, God, it's so easy just to put a screw across that. You know, it'd be a little bit more of a good chance to heal, and it's just a little stab incision. But, you know, we're spine surgeons, and we don't want to be accused of being like too happy, you know, to do surgery and too quick to do surgery. So, you know, it's sort of just common that you got to wait until they fail non-operative before you offer surgery.
So I see.
I might just follow up real quick, Stan.
Yep.
I think one of the other important parts to know too is that, you know, if the fracture heals with fibrous tissue without bony union, it's still healed if the pain goes away. So we don't re-image them because it doesn't matter. If somebody's asymptomatic and they've completed the rehab program, we're going to ease them back into the sport. It doesn't matter if the CT shows it's bony union or not, because a lot of them never go on to bony union and they can still go back and play. But the risk is 6 months later, it's going to flare up again, and there's no way to prevent that. And it doesn't matter what the imaging shows to stop it. That's why we don't re-image them.
Yeah, I'll get to Sue just a second because it goes along with this stuff. But you know, when you tell a parent you have 6 to 12 months before you're going to play again, and the guy's 16 years old, good luck. And which leads me to the next part Sue, one of the things I think we do incorrectly is that we don't fix the problem. The problem was rotation in the lumbar spine. So you can do a stabilization program, as you talked about, pretty much with the spine stable and neutral. But if these guys go back to using the same movement pattern, which is what they do, because they don't get any instructions on rotating their pelvis instead of rotating in their lumbar spine, it's a failure. So I want Sue to address this, but also want to tell two spine surgeons that just stabilization, which is definitely phase one, very important thing. You can't skip that. There's another step to this that leads to failure. Sue?
Yeah, for sure. We've got to be able to reintegrate their movement patterns, as you said. I mean, it's one thing to be able to perform exercises. It's another thing to change somebody's motor program. And that takes time. At the end of the day, it takes thousands of repetitions to change someone's motor program. And if you've ever, I know I've learned that lesson the hard way working in season, where you try to change someone's running form mid-season and it just doesn't work, right? Because it takes time. And that's why where these kids are having lacks of off season, when they're just going back to back to back to back, and they're not taking any time to work on some of these fundamental aspects of their movement, they're running into trouble because there is no off season to work on these things anymore. And I think that's a real problem.
The other thing is the buck procedure. And you addressed this, Dr. Yeung, but maybe you can expand on this. You tell a patient, a parent at 16, the kid's 16 years old, it may be six months before this goes, and it could come back. But we can wait a couple months and see how it does and try to get them back. If it fails, with this easy little procedure, precutaneous, put a nice little screw in this, and now we know it's going to heal. This is analogous to finger fractures, where we used to say don't ever operate on those, but when you put an internal fixation in there, it heals better and they actually rehab faster. What are you going to tell the parents on that one? I want operation.
Yeah, I mean, it's always hard. And you got to have a good, serious talk with the family. Hey, what's the goal for your kid? Is he have a chance to get drafted? Is he going to try to be a pro? Okay, or college scholarship? Then that's a discussion you have. If it's his junior year and he can't miss his senior year, maybe you do something so that he can ensure to have a senior year, and that's all part of the discussion. If he's a freshman, he's got many years, so he can afford a couple steps backwards and stuff. So, it's a difficult situation a lot of times. And especially like you said, you treated it 6 months, 8 months, they're feeling good, they go back, boom, flared up again. Then, then what do? You restart the 6 months, or you fix it or whatever. So
Rob?
it's a hard discussion.
Yeah, and one of the parts about that is, 95% of pars fractures heal without surgery. So if we operate on every pars fracture, we'd be operating on 95% of people who don't need it. And that, that people kind of understand that. But you're right, the most difficult is they flare up at 6 months. Then should you operate? Because if it's a pro, they may end up missing a second season. So I'd be more likely to operate if it flared up between 6 to 9 months in a pro versus a high school kid. And the ones in the middle who are high school kids who think they're going to be pro are the hardest ones.
Yeah, and they all think they're going to be pro, and I think that part of this whole problem is when you say, 95% get better, okay, but the 5% are the ones that the parents are worried about, and they want a more guaranteed thing. And I'll use the UCL as a problem, the thing is that you don't have to operate on every UCL that's symptomatic, but every parent wants them to. And that's the same situation with Tommy John that is actually true, can be of this. If this particular procedure gets out, which I just heard about this 6 months ago from Dr. Yeung, I didn't realize that this procedure was precutaneous and everything else. You guys are going to have some issues with people saying you need to operate. You can operate, or I'll have the guy down the street operate. It's really similar to the UCL issue.
Yeah, that's very true. But also the surgery is not 100% success. Surgery is 90 to 95% success. So
Yeah.
that's something I might mention. One other quick thing is that we fixed a ball player with the PARS direct repair like 2 years ago, came back, started throwing about 6 months into the throwing into the rehab, same pain came back, got a CT spec scan, and the facet joint at the level above the fracture lit up hot. So he never changes mechanics. The same mechanics that cause a stress fracture, and now we're stressing the joint. So if you don't change the mechanics, you can reproduce the problem in a just different way.
That's the movement part of this. And I can't say this enough to the group that's listening, that you're not a pitching coach. You're not trying to teach somebody how to throw a slider on the black, or a football coach. But if they're moving incorrectly, it's just a matter of time, because they're going max effort all the time. And we see it a lot in baseball, and you can see why there's so many injuries in baseball right now. But so I just think this whole movement pattern on this is something, is a take-home portion on this, to be able to do that part of the rehab as well. So anyway, Nancy, a couple more questions from the audience.
Okay, Sue, I know you touched on this in your talk, but there's several questions here that people want to know a little bit more about your aquatic rehab therapy programs.
Yeah, there's not a lot of references out there from an aquatic therapy standpoint for sport. You can find a lot of like really cool meditative. Those of you who know me know I'm super into the woo-woo stuff. So there's a lot of really cool woo-woo aquatic therapy stuff, but not a lot of great sports stuff. I just took what I understood about principles of water. So from an unloading standpoint, if someone's covering their belly button, they're at about 50% of their body weight. If it's at nipple level, they're at about 70%. If it's just their head, it's about 90% of their body weight unloaded. So we can use water depth to change load. And then just principles of water from a resistance standpoint. The faster you move in water, the more resistance you're going to get. The slower you move, the more assistance you're going to get. If you're in that horizontal plane, you're not really going to get much resistance. If you're kind of cutting through the water, you're going to get more. So really understanding the principles of water and being able to apply that to your movement pattern. So I'll do a lot of the exercises I showed you in the videos in the water at varying speeds, because I know I can that way vary the load and the body weight that the person is doing, and I can have them vary the speed of the motion. So yeah, I haven't found a great aquatic therapy reference for you, but if you kind of take the movement principles and combine it with what we know about principles of water, you should hopefully be able to kind of put them together.
Nancy?
All right. How do you feel about stem cell therapy for degenerative disc disease?
Ooh, I want to know this one too.
Not very
Go for it, Rob.
optimistic. Not very optimistic. So one thing about the disc is you have to penetrate the disc in order to inject it. And we know that doing discograms and sticking needle in disc can traumatize the disc and lead to more degeneration. Plus the disc is acidic, hypoxic, avascular. It's a harsh environment. I think almost anything you inject in the disc is going to die within 2 to 6 weeks. Plus the disc is made up of a nucleus pulposus and an annulus fibrosus, and they're the exact opposite in what they are in their makeup. So if you're going to inject something, which one are you healing? Are you healing both? All that being said, I do think stem cells are part of the future. I do think there will be a biologic solution. I just think we're in the extreme infancy of the science, and there's no way I would let somebody stick a needle in my disc and inject anything for at least 5 to 10 years.
Along with that, there is a question out there in regards to, talking a little bit about the annular tears, as opposed to just the disc, the nucleus pulposus, which is bulging out. Do you see a lot of annular tears that do not cause a lot of bulging and pushing on the nerve? And how would you handle an annular tear versus a so-called bulging disc?
I'd treat them the same. It still comes down to decrease the inflammation, the pain, get your core strong, do the rehab. So we treat them the same. It doesn't make much of a difference. I diagnose a lot of people with annular tears. Anybody with significant back pain with increased intra-abdominal pressure, sitting, coughing, we think it's an annular tear that causes 80% of the back pain I see. It's rarely the facet joints. It's, maybe muscle tightness, but it's usually an annular tear. So we make that diagnosis. But the MRIs are not great for diagnosing the timing of an annular tear. You see a little streak in the disc. You don't know how old that is, but it's more of a clinical diagnosis mainly.
Nancy? Couple more.
Okay. Given that conservative care is successful for healing of lumbar stress fractures prior to resorting to surgery, is there any recommendations that any of you give from a nutritional intake standpoint?
Yeah, no, absolutely. In preparing for this talk, I came across a website. It was talking about bone health, and a lot of these kids, they're growing so fast, and they're maybe malnourished. I have kids, and they don't like to eat the protein and the vegetables. They like the macaroni and cheese and the ramen and stuff. And so you definitely need to make sure they have enough supplementation, protein and vitamin D for bone and calcium. So I think that's important, because they talk about having a aerobic bone deficit. So, a lot of it's nutritional, and that's one of the reasons why it doesn't happen in adults. They've grown and their bones are fully formed. These bones are developing, and then they don't have the nutrients to fully develop, then they're susceptible, I think.
In regards to multi-level disease, can you talk a little bit about return to play on multi-level disease as opposed to a single disc, which, you show some great examples of those. And that's typically kind of, I think, what you see, but someone who has multi-level disease in regards to outcomes.
You would think it'd be worse, but we see a lot of football players especially that will have disc desiccation with disc bulges at 3 levels. And you can't believe how often you see that, and a lot of guys have no pain. And so we cannot make a generalization that people with multi-levels of disc that look suspect are more likely to have back pain. Because I've seen a lot of them who never had back pain, got a herniation at 1 level and started having symptoms, but the other things that had been progressing over a couple of years never were symptomatic. So while you would think, like we're asked on prognosis, like, should we draft somebody? Is this a red flag? You would think it is, but I don't know that it actually is, and we don't have any evidence that it is indicative of a future problem.
Since I'm plugging your company so much, where do you see dry needling coming into play for centralized or radicular symptoms?
Yeah, it's a great question. I mean, I think that from a pain control standpoint, we know needling can do a bunch of stuff locally, segmentally, and systemically. So especially our more chronic pain patients, I think needling is a great thing. Lots of different studies coming out on needling. And when I say needling, like, the body doesn't know if you've studied Eastern or Western medicine. The controversy is above the skin, not below it. So, needling can stimulate a lot of endogenous opioid releases. So a lot of really cool studies on people who are addicted to opioids or really sort of overutilizing pain meds, that needling can help decrease the use of those pain meds. So I think especially for our chronic pain patients, needling can help a lot. Acutely, same thing for muscle spasm and muscle pain as well. I think it can help. But I think in those chronic pain patients that are a little bit med seeking and trying to just find some type of a pain relief, needling is a fantastic non-pharmacological solution potentially to some of their pain issues, whether it is central or radicular. Nerves are tough to heal in general, but if we can calm down the inflammatory process that's maybe keeping that nerve irritated, again, I think needling can be a potential solution.
Nancy, one more question from the audience.
Okay, yeah, we still have over 500 people. So, all right. How do you assess, this is for Sue, how do you assess patients' motor patterns, and when do you decide that someone's motor pattern needs to be changed or it's not normal?
That's a good question. One, not during the season. So definitely I may determine that they need some movement work during season, but I'm definitely, unless somebody's out and not participating, I tend to not mess with what is not quite broken. I've definitely made the wrong decision there sometimes during the season. So I try to work on those things in the off season. And I think it's tough to say like what's a normal or appropriate motor pattern. I mean, Stan and I can probably name, anybody on this call could probably name, 12 pitchers right out of the gate that don't have quote unquote normal mechanics, and yet they've never spent a day on the DL. So, I think it's kind of tough sometimes to mess with stuff that's not broken. Definitely not during in season. I would make small changes to people's motor patterns in the off season and see if they are still able to maintain their performance. Their performance level is really key. If I change somebody's movement pattern too quickly and they have a super huge decline in their performance, whatever that metric is, then either they need more time to practice that motion, or maybe it's not the best correction to their movement pattern. So, I think we need to kind of remove that concept of there's perfect motion. I think there's good motion, and we kind of know what that is for most activities, but understand that most people kind of are anomalies, and that's sort of the clinical art of what we do that's based on the science of what we do.
Well, what's interesting, I find the best time to actually, if you want to change something, is during the rehab process.
Yeah, when they're hurt.
People are more open to it, especially if you can relate through video or knowing the player. When you're sitting in the dugout watching a pitcher, and you go, it's just a matter of time. And then when that time comes, they're more likely to listen and be willing to change. Plus, you have the issue of time to be able to do that in a slow progressive pattern as they're starting to do that. We do that a lot with guys who end up with Tommy John surgery, not necessarily the major league pitcher who's, had that kind of situation. It's a little more difficult, but that's really the best time. And it's the time when they're most open to change since something went wrong. Nancy?
All right. With club sports and early specialization becoming an issue younger, what age do you feel there should be a cutoff to see you versus a pediatric specialist?
Ooh.
Good question.
Nobody wants that one.
Oh, yeah.
Is it a referral?
I don't know that there's a specific age, but I mean, typically we start seeing patients getting injured from sports in the tweens, so like 13-year-olds. That's usually when I kind of start seeing patients. If they're much younger than that, then I'd probably say, hey, go get checked out by the pediatric guys. Their bones aren't all formed yet. They have these weird little growth ossification centers and stuff, and those guys are used to looking at all the different stages of that development to help assess what their problem is. I mean, I think also when they're younger than 12, it's not usually like a athletic mechanical problem. Might be something else. What do you think, Rob?
I agree with that.
Set a cutoff?
Yeah, I agree with that. By 15 years old, I see a lot of those. But 12, 13 is a little young. Unless they're a really hardcore athlete, then they may want to see more of a specialist to feel more comfortable.
Yeah. Nancy?
All right. Is it typical to have pain change sides with a pars fracture? For example, one day on the right, one day on the left. And would you expect to see unilateral hamstring range of motion deficits or significant difference side to side when comparing these individuals?
Well, typically it's unusual for it to jump side to side unless they have bilateral pars fractures. If they have bilateral pars fractures, one side can be more irritated than the other. That's usually not like right at the acute injury. That's usually someone who's had chronic problems. They injured it like 3 months ago on the left side, then now it's starting on the right side. And then after that rehab, you could irritate either side. So it can be bilateral after that. Wouldn't be like typically one day hurts here and the next day hurts the other side. It's more like a couple weeks on the left and it kind of subsides, then a little bit more on the other side. And in terms of, I haven't noticed any unilateral tightness based on the side of the fracture. Maybe Sue might have noticed because they're working with the patients more, like measuring that stuff. But I don't think so.
Yeah, Stan might have some more insight there. My population tends to be a bit older, and so Stan, what are you seeing in the adolescent?
I don't think there's been a study that I know of that looks at, say, in baseball. If we look at baseball, because we see a lot of baseball players with this, is whether because they're right-handed or left-handed, or they swing right-handed or left-handed, whether that would cause a problem because you're putting more stress on one side. I think the other interesting thing is, and you can maybe talk about this a little bit, is that, you know, it's a relatively high percentage, if I'm reading my studies correct, on bilateral stress reactions. It's more often than I thought when you look at the literature. So I've never seen a unilateral sport that showed that one side is more than the other on any study.
Yeah, and on my exams, I think their hamstrings are tight equally, but one thing to look out for is nerve irritability. And so if they've got nerve irritability from the L5 nerve coming out under the defect, then that can be more unilateral. And that's where you really want to do a motor exam and check their hip abductor strength and their anterior tib and EHL, because we picked that up, some nerve irritability in stress fractures. You can definitely pick it up, some radicular component. But I think the hamstrings are generally about the same.
Well, listen, guys and gals, this was excellent, and I think we covered a lot of ground and a lot of things, and we sure had a lot of people stay on way past. So hopefully people got a lot out of this. I think they did, and I appreciate you spending all this time and expertise and letting that go out. And thanks a lot. Appreciate it.
Thank you. Thanks for having us.
Bye.
Good to see all you guys.
Thanks for having us, Dan.
Yeah.
All right. Thank you.
All
right.
See you, Sue, Rob.
Good night, everybody.
Yeah. Take care, guys.
See you all.
Bye. Good night.
Bye, Sue.